Good morning, everybody. Welcome to the 19th annual conference for the Maryland Tobacco Control Resource Center. We're so happy you're here. We're so happy my team is here in the back over there. Thank you all for being here and all your hard work. And we want to welcome our distinguished guests from the Maryland Department of Health, from the University of Maryland, Johns Hopkins, and every other place that I did not say. And welcome to our friends and colleagues. Today's meeting is going to be a little bit different from the meetings we've had in the past. We've tried to pack the agenda a little bit, so we'll see how it goes. This will be a learning experience for us. But I'm going to start you off with a couple of introductory slides so you can learn a bit more about our center. So starting out with recognizing our support from the Maryland Department of Health, for which we are very grateful, for supporting all of our activities in this center. I also want to thank my colleague, Melanie Bennett. There she is. Dr. Bennett is our co-lead for the center, so I want to recognize all of the hard work she does with behavioral communities. I want to tell you where the restrooms are, very important. Restrooms are on your left as you head towards the lobby. And the speaker ready room is the boardroom, which is right on that same path. It's all on the left. All of our presentations, the slides are going to be made available to you on our website. And I will show you the website in just a second. What we really need you to do is to not only listen to us and hopefully ask us a few great questions, which will give us some direction forward, but also think about doing the evaluation. So please do your evaluation and turn that in. And we're trying to save these for next time. So if you can just turn your badge and your lanyard in when you're leaving at the registration table. In addition, we want to tell you that all of your CMEs, chairs, any other CEs and such that you are getting will be sent to you after the meeting. So that I think is pretty much my housekeeping remarks. And I especially want to thank our speakers for being here. One of our speakers might be a little late, I think, but we will work around his schedule. So that's our center. And those are some of the things that we do. And certainly these things couldn't be done without a fantastic staff, which I think you all have met. And I want to recognize Michael Dark, Dr. Dark, who has been my right hand in many, many things. And also Julia, Dr. Deepak, and Carissa, who you'll see outside, and Colleen. So thank you guys. Put your hands up, please. Thank you. There she is. All right. Thank you, folks. Want to show you our website. That's our website. It has a lot of depth in it, so we hope you will all get a chance to look at this. You can see that all these tabs here takes you to a different page. Trainings, quitline, health behavior models, measures, conference, resource. Each of these, the resources especially, we really work hard at that. We try and find you the nicest, newest, and we post them up there so you can see what you would like. We are beginning a lung cancer page for resources for folks who smoke and develop cancer as well. Some of our activities are on this. We've had a board meeting. How many of you attended our best practices meeting last year that was online? Show of hands. Just a few. Great. So this will be a new group, and we have about 105 today on the Zoom call. So in addition to you all, there's another 105 people, and Michael will add them as they register as well. So thank you all for being so engaged. And I will now move us on to our first speaker. And I see Dr. Owani Koko has just walked in. Thank you. So I'm going to introduce him to you. Yeah. Okay, we are very honored to have a distinguished speaker today. Dr. Taufik Owanikoko is the Marlene and Stuart Greenbaum Distinguished Professor in Oncology and the Executive Director of the University of Maryland NCI designated Greenbaum Comprehensive Cancer Center. He also serves as the Senior Associate Dean of Cancer Programs and Associate Vice President of Cancer Programs at the University of Maryland, Baltimore. He's a board-certified oncologist, hematologist, and internist, specializing in lung cancer management and translational research, focusing on experimental therapeutics, biomarker discovery, and clinical trials. Dr. Wanikoko is also a board member and treasurer of the ASCO and serves on the Lung Cancer Research Foundation Scientific Advisory Board. He's on the editorial boards of multiple journals and has over 250 peer-reviewed publications in leading journals, and his research has generated 58,000 citations. Oh my God. And an H-index of 91. And he has secured significant funding from every agency you can think of. So Dr. Wanikoko, we're pleased to welcome you to the stage.
Yes. Yeah. Good morning, everyone. Thank you so much, Dr. Kanner and the organizers for the opportunity to be part of this important symposium. I'm really glad to be here. My second year back in Maryland, and it's really exciting to see such a strong attendance at a meeting like this. I've been asked to talk about tobacco and lung cancer, and I was thinking of the audience, and what I do is a little bit far removed from what we maybe focus here. We wait on the other end of the spectrum for what we can do to help the patient when the damage is done, when it's a little too late, I would say. But I think this is an important step for us to be able to break this cycle of tobacco and all the morbidities and mortalities associated with it. So I'll give these, those are my disclosures. This should not have anything to do with the content or presentation of my talk. So I think for this audience, this is probably not news, but I just want to use this to set the context for my talk. When we talk about tobacco, it's actually not a new thing in the Americas. People will tell you people have always used tobacco in different forms, whether as pipe or chewing tobacco and things like that, or even sniffing it. But what differentiates tobacco use, the general tobacco use, from what we are trying to talk about today is how tobacco has become a main carcinogen, a driver of morbidity and mortality for patients. And historically, if you go back, I think there are key steps that really played significant factors into how we came to where we are today about the damage that tobacco is causing individually, but also at the societal level. So in 1884, there was an invention made, which was to enable you to be able to manufacture cigarettes. So rather than relying on you wrapping your own tobacco and chewing it or sniffing it, you actually have now the technology to be able to make cigarettes. But as you see there, in 1880, between 1880 and 1920, that actually did not move the needle. A lot of people were not still using tobacco, cigarette. They were using tobacco the way they've always used it. But then in 1913, somebody figured out, well, you need to just let people know that this is available. So they started marketing cigarette as a way for you to use tobacco. And you can see that inflection point there in 1910. Now that's when the uptake in the use of cigarette actually took off. And majority of people who are using cigarette then were males. So the industry look at who else are we missing out on that we want to bring into the fold. So in 1928 was the introduction of cigarette advertising targeting women. So about 20-year delay between when men started using cigarette to when women were actually targeted for them to become part of that crowd. And then in 1955 was the introduction of filter cigarette. And filtered cigarette was marketed as a way for you to use tobacco in a safe manner. We all know now, 50, 70 years later, that that was actually not true. In 1970, there was counter-advertising saying, well, cigarette is bad for you. Whether you use filtered cigarette or not, it's still going to cause you harm. And between then and now, with a lot of work that a lot of people in this audience are currently doing and a lot of work done in the past, both in terms of advocacy as well as patient education intervention, we've seen significant decline in the use of cigarette. This went all the way to 1990, but you can actually assume that in the more recent decades, the use of tobacco nationally has really gone down, although there are still areas of inequities that we'll talk about. While the focus is going to be on lung cancer, I want to emphasize the fact that tobacco is an equal opportunity destroyer. It doesn't just damage the lungs. It doesn't just cause lung cancer. You can see that tobacco contributes to a lot of other cancer types across the entire body. The only thing that you probably don't see there is maybe skin cancer, right? But every other organ in the body that develops cancer, there is some attributed risk factor to tobacco use. So lung cancer is not the only thing that we are trying to prevent when we want to help people to stop using cigarettes or even prevent them from starting the use of cigarettes to begin with. And the work that we're all doing is meaningful. This has translated into better outcomes for patients. This is actually the latest data in terms of cancer diagnosis and incidence in the US using the SEER database. And what you see there on your left is the incidence of cancers of various types in men and women, where prostate and breast cancer remain the most common. But lung cancer, fortunately for us, since we are focusing on that, if you look at the incidence of lung and bronchial cancer in men, it has continued to decline since the 80s. You do not see a similar trend in women. This is attributed to two things. One is that women started using cigarette at the same level as men about 2 decades later. So everything that we saw in men will take about 2 decades for it to manifest in women. So that is one. The second is it appears for some unclear reason now that women tend to have much more difficulty coming off of cigarettes once they've taken up that habit. So that is also why that rate of decline in women is much lower than what you are seeing in men. But regardless of where we are in terms of the incidence, the mortality is actually improving in both men and women. And those of us who treat patients with lung cancer, we are always patting ourselves on the back that we are going to be out of job very soon when we no longer have patients that we have to treat with lung cancer. As you can see, the lung cancer in the next few years may actually turn out not to be the most common cause of cancer death in women. And the same trend is appearing in men. So, which is good news. A lot of work that we're all doing collectively is beginning to impact the outcome for patients. But what else can we do beyond helping people quit or not taking the habit to start with? Is there are now tools that we know can be very effective. So screening for patients who have had exposure to tobacco, who are at high risk of developing cancer, and specifically talking about lung cancer now, we know that there are effective tools that is proven that can be used. And one of those is low-dose CT screening. These are 2 trials conducted here in the US as well as in Europe. And both of them showed 2 things. One is when you use low-dose CT screening, meaning low dose of radiation when you obtain the CT scan to detect for cancer at the very early stage, you tend to detect more cancers and you detect those cancers at a much earlier stage when it is curable. And when you do that, you actually improve the outcome for patients. So that results in increased survival for patients. Because there are a lot of things that we can do to find cancer, but it may not translate into better outcome for patients. And you ask yourself, why do you do it? But there are some limitations to low dose
I can't hear this
screening.
man. I can't.
One specific limitation I want to point out is it is not the panacea for everything lung cancer. It actually, if you look on the right side of the screen, when you look at patients with adenocarcinoma or squamous cell lung cancer, when you use low dose CT screening, you are better able to detect more cancers and more of those will be at the earlier stages. So you have a stage shift when you use low dose CT screening. When you look at small cell lung cancer, You detect more, but there was no stage shift. So what we do currently does not work for small cell. And when you ask, what is the subtype of lung cancer that is most attributed to tobacco exposure, it's actually small cell lung cancer. So if you're going to rely on low dose CT scan and the solution to our problem, it's not going to help patients with small cell lung cancer. The other thing is when we look at all the various cancer types where we have screening modalities approved based on the USPTF recommendation, that includes things like lung cancer, cervical cancer, breast cancer, colorectal cancer. Some of these also impacted by tobacco use, not just lung cancer. When you look at that population and you look at the number of patients who are at risk, only about 40% of cancer diagnosed currently in the US are going to be impacted by any one of our screening efforts. And when we realize that about 30% of patients who develop lung cancer, when you look at their profile, they will not even qualify for the USPTF recommendation for low dose CT screening, then that population that we are playing for, that we are trying to help, becomes even smaller. So only about a third of cancer patients would benefit from any one of our proven screening methodologies currently. So there has to be other things that we can do, that we can bring to the table to help address that problem. And it's not just a national problem. When we focus down on our own state of Maryland, in 2024, we expected about 36,000 new cancer diagnoses in the state of Maryland, resulting in about 10,000 deaths, unfortunately. And majority of those patients will be patients with advanced stages of cancer, especially if you look at the number, about a fifth of those will be lung cancer patients. So we have our job cut out for us. And even when we talk about finding those patients and finding them early with the tools that is already proven, this is American Lung Association data, that we only reach about 3% of the at-risk population in the state of Maryland. So about 97% of our patients that potentially could be helped with these tools, we're not even reaching them. So there is a lot more that we can do. Number one, maybe help people not get into that risk pool so that they do not need to depend on the CT scan to find the cancer for them. And if they're already in the risk pool, then we should figure out a more effective way of finding those patients and offering these tools for them. At the Greenerbound Cancer Center, the whole of Maryland, the state of Maryland is our catchment area. That is the way we operate. But in terms of the official definition of our catchment area, you can see there is Baltimore City and the 10 surrounding counties. That is what we tell the NCI we focus a lot of our efforts in. But so rest assured that we do not leave any part of the state behind. Anywhere you have University of Maryland Medical System, we're there. Anywhere our community outreach and engagement folk can go to, we go to help the community. But this is about 80% of Marylanders live within our defined catchment area. Home to 5.4 million people, very, very diverse, about a third of them being African-American, 11% Hispanic. So we know that when you look at what we call our catchment area, there are things that we can do to make things better. But let's even zone out and look across the country. We know that when you look at low-dose CT screen as a tool to help patients, there's a lot of unmet needs. And what this map is showing, this heat map, what you can quickly surmise from here is a lot of the unmet needs when it comes to low-dose CT screening is actually in the high population areas. Whether you look on the East Coast or the West Coast or the South, where you see those hot areas where you have a lot of needs are the high urban population areas. And this is what this looks like for us in the state of Maryland. When you compare our metrics to some of the national numbers, and you can see there, if you overlay this to what I showed you before as our catchment area, it's almost like this is speaking to our catchment area, that there are things that we're not doing well in. And 4 of them highlighted in red in that table, you can see that the total annual incidence of cancer count, we have very high number of diagnoses. Mortality count is quite high relative to the national number. Average mortality is higher than national numbers. And the average positivity rate, if you go out to screen, you are more likely to diagnose patient with cancer in Maryland than if you did it just looking at the national numbers. So there are a lot of things that we can do to help move the needle and improve the outcome. As we know, there's been a lot of advances made in terms of treating patients with advanced stages of lung cancer, even early stages of lung cancer in terms of surgical techniques, radiation techniques, as well as therapies. Lung cancer is no longer one single disease. What I'm showing you here is just a pie chart that shows the different molecular subtypes of lung cancer. Counting now, we have about 20 different types of lung cancer that we treat with specific types of drugs that would not only work for that subtype of lung cancer. This has improved and has helped a lot of patients, but it's only a small component of what is driving the improved outcome that we want to see in our patients. And these are very, very expensive drugs. While we've made progress, this is looking at the last 80 years in terms of what we had to treat patients when they've developed lung cancer and advanced and it's no longer curable. Most of the advances we've made have actually been in the last 20 years. 40 years ago, we had only one chemotherapy drug. And if you try that and it doesn't work, we're done. Now we have more than 20 different types of drugs that we can offer patients. But unfortunately, when we're doing that, we're playing catch up. These are not curative therapies. So the real impact that we're going to have is to stop people from getting into that at-risk pool. And if they are in that pool, for us to be able to identify them early. Not to discount what we're getting in terms of mortality impact of this agent that we're using in the advanced stages, I just want to emphasize the fact that we cannot sit at that end of the spectrum and think that that is where we're going to make most of the gain. Most of the gain is actually going to be in prevention and early detection. But suffice to say that these are effective drugs. They've led to improved mortality for patients. And this is not just because of reduced incidence of cancer. It's not because we're detecting those cancers early. These drugs actually do work. So we know that this is an effective thing for us to offer patients, but it's not going to be the strategy that we rely on to get to where we want to get to. Now, this is hot off the press that just came out yesterday to emphasize the fact that what we are talking about here today is very, very critical. So this is the impact of all the prevention efforts when it comes to tobacco use. In the last 50 years, from 1970 to 2022, prevention and treatment efforts in terms of tobacco cessation has actually saved more than 4 million lung cancer deaths in the US. That's about 76 million life years saved. And that is both in men and in women. So you can see that what we are here to talk about is very, very important. And this is just looking at lung cancer, like I showed you in the beginning. Lung cancer is not the only problem we have when people get exposed to tobacco and all the downstream consequences. You also look at the trend in tobacco consumption. It continues to go down. Over the past 80 years in the US, we've made significant progress. A lot of consumption has gone away. But what has not gone away, unfortunately, is the disparity across states. It appears that some states are doing really well with their tobacco control efforts. Some states are not doing as well. And when you project this out, there's actually going to be much more of a problem in terms of state-to-state inequity in tobacco consumption than you're going to see within states. So when you compare a state like California, for instance, to Missouri, by 2030, you're going to have 7 times as many tobacco users in Michigan as you're going to have in California. And when you look at Missouri, it's going to be about 10-fold higher number of people using tobacco compared to California. So we have to not lose sight of this as we continue to come up with strategies. From state to state, we have to learn from one another to see what works and what can move the needle. And let us not forget, there is a big industry behind the use of tobacco, and they haven't gone to sleep. So we cannot afford to sleep either. I'm just using this as an example of something that was sold to the society as, oh, if you do it this way, the risk is gone away. Just use filter cigarette and you'll be fine. This was when we were still allowed to advertise cigarette. And people say, oh, this is it. Now we have the filter. Canned cigarette, the best filter in the world. Just use our cigarette and you'll be fine. We know that that was actually not true. Tobacco industry knew that before they marketed it. And people suffered from that. I'm bringing that up because what got us here may not get us there. One thing that happened when people started using filter cigarettes, it's not that the number of cases of cancer continued to rise, but actually the type of cancer that we were diagnosing started to change. It used to be that squamous type of lung cancer was the most predominant type of lung cancer. With the introduction of filter cigarette, that actually flipped. That was observed here in the US, and on the slide there, more recently, was also shown in Asia, that you saw a declination in the number of patients diagnosed with squamous cell lung cancer compared to adenocarcinoma when there was a significant uptake in the use of filter cigarette. I'm bringing this up now because now we are vaping. That is now being marketed as that safe way of you to get something into your lungs. While the data is still very, very preliminary and not yet mature, I think the signal is beginning to show. On your right side is recent data from Ohio State, where they looked at population level data of smokers versus non-smokers and compared those smokers who used vaping along with tobacco versus those who only smoked. And it appeared from this data that when you combine vaping with tobacco, you actually triple the risk of developing lung cancer compared to non-smokers. So I want all of us to keep this in mind as we continue to do our research and do our outreach. Because the total amount of tobacco use is going down, we may actually not see an increase in incidence immediately, but what we have to watch out for is whether the type of lung cancer that we're diagnosing is changing. But that could be the earliest signal we're going to see with the use of vaping going forward. So I've talked a lot about the problem. So what are the solutions and what can we do locally? And I just want to leave you with some of the efforts being led by a lot of people in the audience, Dr. Sachdeva, Dr. Kana. They're all taking a significant lead in this partnership that we're now pushing forward with support from AstraZeneca, another good citizen of the state of Maryland, where we want to live our mission as an NCI designated cancer center to undertake innovative basic clinical and population research, focusing on prevention so that we can provide the best and the state-of-the-art clinical care to cancer patients in Maryland and beyond. But part of this effort is not just taking care of cancer patients. We also want to make sure that we actually prevent people from becoming cancer patients. And that is why this is a well-intended program where we're not only thinking about expanding access to low-dose CT screening across the state, we are also looking at other innovative ways to reach out to patients, other ways to help them quit tobacco use, and understand why people may or may not want to explore these tools that are out there. And whatever lessons we learn through this work over the next 5 years, we also want to be able to come to a conference like this, share the lessons, and then use that to help other communities to get better. So briefly, this is where we are now, putting this together with Dr. Sachdeva's help. We've put a governance structure together. We have some funding support from AstraZeneca to help us with this, so we have the budget laid out. We are working through our workplace and technical capacity and capabilities, and then eventually roll this out, initially within our own medical system, and then ultimately out into the community. This is not by any means for you to recognize any name. It's just to show how comprehensive an approach we are taking with this effort. And I want to specifically call out what you see there towards the bottom, tobacco treatment, led by Dr. Deepak and Dr. Kana, which speaks to a lot of what we are going to be talking about during this conference and beyond. We have this set up in different phases. The phase one is more about providing access to what is currently available. And then the phase two is innovative approaches to getting things done better and quicker. We're going to, at the end, be able to characterize the pattern of lung cancer diagnosis in the state of Maryland and understand how and why we screen and how best to screen patients for lung cancer. Is a very, very comprehensive program that's going to extend from tobacco treatment all the way to lung cancer screening and incidental nodule, lung nodule management. So to summarize, tobacco use continues to be a major driver of major mortalities and morbidity here in the US, including lung cancer. There has been significant decline in the amount of tobacco that is consumed nationally, but tobacco smoke exposure continues to be the main risk factor for people to develop lung cancer. Efforts such as this are more likely to confer greater benefit at the population level than early detection of cancer when it's already developed or any innovative therapeutic strategies that we can come up with for those with advanced stages of lung cancer. And newer methods of inhaled carcinogens such as vaping and other delivery tools deserves our attention, because if we do not pay attention to this, a lot of the successes that we've witnessed over the past decades may actually elude our patients. And with that, I want to thank you again, and I'll be happy to answer questions. Thank you. Yes, Dr. Deepak. Yes.
Oh, sorry. I used the microphone. Sorry, I apologize. I have a very loud voice usually, so I try not to speak on the microphone. So my question is, you mentioned about the lung cancer screening and how we are not going to be able to diagnose small cell lung cancer, which is the absolute tobacco related cancer. It's lovely to be able to diagnose adenocarcinoma and squamous cell carcinoma at early stages, but then do we have anything in the pipeline to be looking for small cell lung cancer? And I have a second question, so I will on. And in terms of the vaping, is there an indication from cell line studies as to the histology that we are seeing of cancer? Thank you.
Thank you. Those are two very important questions. So with regards to the first question about how can we better improve low density screening to be able to diagnose small cell lung cancer early? Right now, we do not have any proven strategies, but there are some promising tools. There are now some publications about blood-based markers that are specific for small cell that potentially, in combination with low density screening, will help us identify those who are more at risk. But you cannot deploy it without some type of selection. When they've looked at those markers, you have to have another layer of selection for you to know who to deploy those blood tests in. And what is appearing to be the most useful tool would be the amount of tobacco that you've used. So those with the highest quartile of tobacco exposure, probably that is where you want to deploy it. And if that test is positive, then the question is not whether low dose CT screen will diagnose the small cell. It's going to diagnose it. What you want to do is diagnose it early enough for it to be curable. So the current strategy of doing annual CT scan may not work for small cell. So that may be where we have to combine that blood-based test to say, well, we are not going to wait for next year for you to get your next scan. Maybe you need to come back in 3 months or 6 months. So we have a lot of work that we have to do in that regard. But that is the way people are beginning to think about improving low-dose CT screening effectiveness. With regard to preclinical work, when it comes to vaping, there's been work shown that when you expose immortalized cells to vaping, the chemicals in vaping, you can actually induce DNA damage and then turn those cells into malignant cells. We've not had enough clarity as to whether or not you have a specific type of lung cancer being developed. All that has been shown is that vaping, the content of the chemicals in the vaping tools and also induce DNA damage that would then transform those cells.
Hi, I was wondering if you have seen any studies, are they comparing the pathophysiology of certain cancers, not just lung cancer, but from those who were traditionally combustible cigarette smokers versus vaping? At least that's something I'm concerned about, is that these cancers have a much more, are they having a much more aggressive pathophysiology than your traditional combustibles?
Interesting question. I'm not aware of any robust data to show that the behavior for cancer developed in the context of vaping is different than those that develop in the context of traditional tobacco use. The one thing we know, though, is when you look at patients who had used any of the vaping devices and developed lung cancer, tends to be a little bit more aggressive histologically. But we do not have clinical data to show that that histological appearance turns into very, very bad clinical outcome. I think we still have to await significant data to mature in terms of what happens in those patients.
Yes. So thanks, Dr. Wonigoko. That was an outstanding presentation. As I was listening to you, it is very evident that we are not just talking about lung health, we are talking about human health with tobacco treatment. Could you expand on the advocacy efforts for destigmatizing the tobacco use and its association with cancer, and tie it to what efforts we are doing for past exposure to passive exposure of smoking or never smokers, especially women?
So the question about stigma when it comes to tobacco use, I would say that tobacco use is not the only bad thing that we all engage in. So there's no reason why we need to call one out and leave the other habitual things that we engage in that may put us in a bad state of health. But it is real. A lot of patients feel the stigma, number one, when they get diagnosed, not just with lung cancer, but any type of condition that's associated with smoking, whether it's heart attack or stroke. They have the sense of they feel like make them realize that, oh, you brought this on yourself. And if you didn't smoke, maybe this would not have happened to you. But we also have to recognize the fact that about 20% of lung cancer patients are actually never smokers. And when you look at the trajectory, that is in the US. If you go to Asia, it's about 30–40% of patients in China and India developing lung cancer are never smokers. So it is very, very tough on the patient, especially when you have someone who never smoked, or somebody maybe they have secondhand smoke, because that is also known to be a risk factor, maybe not as strong a risk factor as being the primary smoker, but being exposed to tobacco when you are not the primary smoker is also a risk factor. So we have to take the stigma out and focus more on what the problem is, which is what part of what we are trying to do. Make it such that people actually recognize that this is not something that is good for your health. Instead of waiting when it's already too late and now start blaming them for, oh, why did you do it? Why did you not do it? We have a lot of investment being made into advertising, getting people hooked on some of these so that continue to generate the revenue for those companies marketing tobacco products. And then the last question you had about in women. So when we did not know why people never smoked, who were developing lung cancer, all we had was just look at who are these patients. And we started out thinking, well, they tend to be more likely to be women, more likely to be people of Asian ancestry. And if they smoked at all, it's very, very minimal amount of smoking. Now we understand why people develop lung cancer when they never smoked. Actually, most of it is driven by some genetic changes that leads to the development of cancer. Now, why did those genetic changes occur? That is part of the work that we're now trying to do. And some of the emerging data will suggest that part of that could be other environmental exposures, especially microparticulate matter that people might get exposed to with in Asia, for instance, what is now being maybe considered a potential culprit, open flame fire. That people use a lot of open flame to cook, and when we think about it traditionally, especially in commercial setting as well as in the personal setting, women are more likely to be exposed to that type of environment than men. So that was the belief that maybe in Asia, the reason why this appeared to be more women, more Asian ancestry, just because we are looking at the population that is exposed to that risk factor. But that is still something that is worked on, that is not yet fully established. But the preponderance of the data would suggest that even when you do not have tobacco exposure, you may have other environmental exposure that may put you at risk of developing lung cancer.
Can I ask one more question? Do we have time? Hi, over here. Yeah. Can you speak on the incidence rates of other cancers in never smokers? Like, are we seeing as like a result of secondhand smoke, aside from just lung cancer?
Instance of other cancer types in never smokers or secondhand smoke?
Correct.
Tough one. I actually do not have any reliable data to share in that regard. Yeah, I'm sorry.
That's okay. Thank you. Just
Thank you for that wonderful talk. In the interest of time, we're going to move right into our second speaker, and that is my partner in crime, Dr. Melanie Bennett, our co-lead for the Tobacco Control Resource Center. He's a professor and director of the Division of Psychiatric Services Research in the Department of Psychiatry at the University of Maryland School of Medicine and a psychologist by training. He conducts practice-based research to test and implement services that improve health and support recovery for individuals living with mental illness. The focus of this work is testing ways to integrate tobacco treatment within mental health services. And we all know that she has already reached almost 1,000 people with her behavioral health training. So today she's going to share with us some of the learnings from that trainings that she's done.
Forwards, backwards. I got it. Yep. Can you hear me? Hi. So everybody go into your black folder. You will see this handout. This is our TCRC behavioral health, kind of a tobacco treatment 101 training. I am very lucky to have the support of this center. And my training team is over here, wave, Brian Brandler and Ian Rivera, and Anastasia Fedosova isn't here, but if she was, she'd be waving. We are trying to reach you and everybody you work with and train and know in the behavioral health treatment providing community. So pass it around and pass it along. I have a great job in the center because you heard in the last presentation how important it is to help people who use tobacco to stop. And so my job is to marshal the great motivation of the behavioral health treatment community to this challenge. And it is a challenge. Lots of us have been at it for a while. You saw that the very first slide on how long smoke's been around. Well, some of us have been trying to do work to convince people to not smoke for much of that time. So it's not often a thing that is an easy fix. So my job is to say, but it is something that we can really make a difference in. And we, the behavioral health treatment community, are the people to do it. So me and my team go around and talk to whoever will listen and try and get them all psyched up to work on tobacco. with the people that they serve. So I'm going to tell you a bit about that and what we've done and how we think it's good, and then where we need to go next. So this is a little bit about, we don't care. This is a little bit about what I'm going to do, but I want to start with, so I came to this and we had some training slides and things that we were able to use, which is great. And I took a look and I said, well, I think there's things we need to figure out here. One is how to incorporate new things that we've learned, because there's a lot of new information around tobacco treatment that a lot of people don't know. And the other is to find out, well, what do behavioral health treatment providers want to know in a training? If I'm asking people to show up and I'm trying to psych them up to treat tobacco, my guess is a lot of people know a lot of things. So we needed to figure out what do people want to know. And I'm really lucky because in my, right near where I sit at the University of Maryland School of Medicine, I'm in a department of psychiatry that has all sorts of talented and accomplished clinicians providing mental health care and substance use care. So I was lucky that I called up some friends and I said, can I come and pick your clinical brains about what you want to know? And this was what I learned. I thought there would be a really long list of things. These were people, all types of providers, have psychiatrists and other types of prescribers and nurses, but we also had social work, counseling, a few psychologists, and peer support specialists, a lot of different types of people working on this issue. And the list of what they really wanted to know, if they really didn't know, wasn't so long. Everybody said, it's hard to keep track of the medicines. Help us keep track of the medicines. It's great because the medicines work. If people can keep track of them, have a nice organized way to do that, they're going to be better able to talk about it with the people they work with. So check. A lot of people said, if I can't do it, who can? Like, who can provide this service if I can't do it? How do I refer? And what do I do? So I said, okay, this training will clearly talk about resources and how you refer to them. Everybody is confused about vaping. And I had a special plea. What do I tell people I work with when they say they want to use vaping as a way to quit smoking? So we have a whole bit of our training that's dedicated to that. So you can see some of the other things that people asked, and we tried to organize our training around what people wanted to know. So we have a couple types of things that we do. I want to start with our quarterly trainings, and that's the handout that I asked you to take out of your folder. So 4 times a year, anybody who wants is invited to a 3-hour training session. And 3 hours is no joke. You really have to want to know something if you're willing to sit through 3 hours. But what I am finding is that people are really interested. There's an interest in having good, up-to-date, actual information that clinicians can take with them and then use. So we have been shocked and delighted by the response, and we get a lot of people coming every time. The number that I have here was from a few weeks ago. I noticed Dr. Khanna had a different, she must have been counting them differently. I can tell you that we have a training coming up at the end of April. We have over 400 people already signed up. So what that's, and you can see by the map, which is a very cool map that Ian figured out how to make, so thank you. You can see that the word is getting out. We're going to make a real push to get these trainings advertised to certainly the counties where we're seeing people come from, but the counties where we don't have representation yet. But people really want to know about tobacco treatment, which is great. Ugh, this slide is terrible. I'm sorry if it's a little mushy and you can't see it, but I'll tell you what it says. This is just a graph of who we're reaching. And the top bar is mental health treatment programs. So we're getting a lot of those, and we're getting a lot of places that do both mental health and substance use work. That's the third bar. And other is made up of a whole bunch of other sorts of places that are maybe not dedicated to mental health treatment or substance abuse treatment, but see people who have all of those sorts of issues and who are tobacco users. So I think we're reaching people who work with people who use but we are open to, we'll take anybody, and we're open to any kinds of suggestions from anybody here about what sorts of places we should be reaching. So we collect surveys. We ask everybody, or as many people as are willing to do it, to fill out a pre and a post training survey, and then we try to follow people up 3 months later. So you can see a little bit about our surveys, and we're generally, I think people are generally find the training useful. They're getting a lot of good information, which is great. Maybe I'm a glutton for punishment, but I think the true learning and how we do a better job is to look at people who are like, oh, whatever, and think about how to improve in that way. So we take the surveys pretty seriously. And the least helpful part is what I'm working on next. If people are going to come for 3 hours and they need more practical tools for youth, then I either need to provide that or I need to co-present with somebody who can provide that. So we're taking a look at some of the things that people would like to see that would make it more useful to them. I'm not sure what to do already knew about some of the content, but we're thinking about this, tobacco treatment 101 as a first step. And maybe we'll ask some people, well, now that if you want to go more in depth, what's the next step? And we can have a 201 level for people who already know a lot of the intro stuff. So we're starting with the big quarterly trainings. What I really want to have happen is that an organization or a person from those trainings gets motivated and says, okay, now that I know this, I want my organization to do something more, or I'm going to change in my practice so I can do something more. That's really what makes the difference, taking the learning, implementing it in some way. So this slide shows a sampling of organizations that have followed up after the training. And what I'd really love is more and more organizations to follow up after the training. And we'll do whatever an organization wants. So you can see, or maybe you can't see, I'll tell you a little bit about what we do. So sometimes an organization will contact us afterwards and say, okay, you talked about some group intervention. That's pretty new to us. Can you do some time just with us, take us through the manual, do some practice, do some role play, and help us figure out how we would get this group started? Yeah. Sometimes an organization says, all the clinical non-prescribing staff came to your training. Our prescribers need quick and dirty. They don't have 3 hours. They need 20 minutes, and they need to know about the medicines and the interactions. And then I say, yes. And I get my colleagues who know all about that stuff, and we come up with a time, and they get that. We've had one organization say, okay, there's a group of us working with pregnant women. Can we follow up with you about that? Yes, I'll find somebody who specializes in that, come and talk to them. So we're really hoping that programs and organizations follow up, tell us what they want, and then we'll deliver. And you can see we get these requests in different ways. We're trying to meet people and programs and organizations where they're at so that they can do it, take the knowledge, and they do. What I really want, though, and where I think the most bang for our buckets, is when individual providers feel inspired. Hey, this makes a difference. I can talk about this. I'm a little hesitant still. So at the end of all of our big trainings, we say, I will meet with anybody individually, and we can go through your practice. What are you worried about? And get that person feeling more competent to talk to people, the people that they serve around tobacco use. I really think that that's how each individual changes. Their provider says to them, hey, let's talk about this. Let's figure out what's holding you back. Let's get you ready. So when the time is right, you're going to feel like you have the tools that you need. So again, people can call me or follow up individually. Someone in the audience who we talked to yesterday was amazing. We had a million ideas. I don't know if any of them can actually happen, but after an hour, I felt really energized, and I hope you had some ideas too. I think what we're going to do in the future, so I don't get a lot of offers for that, which makes me sad because that's what I like to do most. So I think what we're going to do right now, and in the quarterly trainings, I say, please follow up. I think what we're going to do is like sort of outreach to the people or a program. If a lot of providers from that program registered for the quarterly training, we'll then follow up with a personalized, hey, we see that you are all here. We want to go the next step with you. Let's make a time to meet. So I think coming out more active around that. And then finally, I think that the thing that takes it from knowledge to practice to really feeling confident is you try something out and then we all get back together, say to each other, well, you know, I can talk with people about what felt good, what felt weird, what do you think went wrong, what do you think, why aren't people coming to your group, you're offering it, or why are people loving the group but not making changes in their smoking. So ongoing consultation. We haven't done any of that yet, but I know in my own practice, try something out. And when I feel, I don't know, shaky about it, the best thing I can do is go to somebody or have a group of people who are all trying to do it. And we share what successes are, but more what our challenges are, and we learn from each other. So our team is working on developing an interest in this. Not quite sure what we're going to come up with. Maybe we'll just have like a consultation office hour and we'll publicize it and people can show up or not. I don't really know. That's on my to-do list for this year. So that's what we're doing in training. And I hope to see you all at a quarterly training or some other training soon.
Got volunteered by me. I'm sorry. He's our medical student and is going to share with us what Gen Z thinks about vaping, tobacco, etc. And then Brandon, who's actually related to one of my team members, is a health education teacher in one of the public schools, and he's going to share with us what he thinks about vaping and such in middle school. So, floor is all yours.
Hi, everyone. Good morning. My name is Austin Kim. I'm a second-year medical student at the University of Maryland. Today, I'll be speaking about the Gen Z perspective on vaping and quitting. And this talk isn't, based off facts or any data. It's just from what I've gathered, experiencing the world, and during this peak of vaping. And also, I'll be drawing from my personal experiences because I used to be a vapor. And so I hope to provide some insight as to why the youth and young adults vape and the current perspective of vaping. So here's the outline. I'm going to just go into the why. Then it's the attractive properties of vaping and the changing views on vaping and quitting. So why does Gen Z start vaping? I think a lot of it stems from mental health. While you have a large group that starts vaping because their friends start vaping and it looks cool to them, a lot of it also deals with mental health. So many of my peers, myself included, I view vaping as like a kind of a tool, similar to caffeine, because of the growing competition and the demand that comes with education and career. I think we like to use vapes to remain focused and energized, either gain a competitive edge or just to help complete our task. And I know I'm very guilty of this because if you take my career, for example, admission to medical school has become very difficult over the years, and it only gets worse and worse. So when MCAT scores increase and GPA averages increase, and I'm like, okay, in high school looking at these stats and I said, okay, I need some help with it. And so more and more people want to become doctors and have incredible resumes. And so I had to work a little bit harder. And to do that, I used vaping. And I remember when I attempted to quit during the sophomore year of college, I used to get, my GPA first semester was around 3.9. And the semester that I tried to quit, it dropped to 3.3. And so I was like, okay, I need to get back to vaping, unfortunately. And I did. And it wasn't because I was craving nicotine or had withdrawals. It was literally just because my GPA dropped. And the same can be said for many of my friends who are in different fields like engineering, computer science, investment banking, where a lot of them after graduating school, they applied to over 100 jobs. Literally 100 jobs and heard nothing back. And so because of that, they decided to pursue a lot of unpaid internships where they worked 100-hour weeks, and they used vapes to get through it. And because of the society we live in right now, the younger generation, while other generations have gone through tough times as well, we live in a unique position because I think the availability of social media, we have so much information that, at our hands, and you can just scroll through like TikTok and Twitter and see all this bad news, and you start to get worried, and it perpetuates the idea that everything's a competition, so it makes everything worse. And I've seen a lot of people vape because they just want to get through things. The second reason why Gen Z starts vaping, I think, is because of a lack of information. So I started vaping in 2016, so when I was 16 years old. I remember when my friends used to ask me if I thought that vaping was as bad as cigarettes, I said absolutely not. In my head, it was like, oh, it's just like water vapor. You're just vaporizing it, nothing's actually burning. And so I spoke with my friends about this, even now, and they had the same belief before. And at the time, even when you quickly just ran a quick Google search, nothing would really pop up. And things like vape-induced lung injury wasn't a thing. And so I think this lack of information was a big part of like the reason why a lot of the youth start to vape, because you saw in comparison to like cigarettes, growing up, I had a lot of smokers in my family who described to me, oh yeah, I smoke because it feels good and I'm addicted to it, but you should never do it because of all the health risks involved, right? And you've seen family members diagnosed with cancer and things like lung disease. And that was enough for me to stay away from it. But then once I heard, oh, vaping is a lot healthier, quote unquote, right? I was like, okay, I can get all the benefits from it and have no health risks as a naive teenager. The third thing I think is the biggest component of why Gen Z vapes, and I think it's just the culture behind it. I have this picture here of the packaging of different like e-liquids, and it looks like typical candy bars and sweet treats that we eat on a daily basis, right? I put this here because I think it definitely contributes to it, but because of social media, which is a pretty recurrent theme in this presentation, I think our biggest worry is the youth like to just literally market themselves, right? So a lot of companies, I don't think they need to spend a lot of money on marketing anymore. If you make a trend and it goes viral, that's marketing in itself, and that's, I feel like, the modern strategy for the youth. Because of social media and how impressionable the younger generations are, like I said, we quite literally market to ourselves. I think the biggest driving force in the prevalence of vaping in youth is what they see amongst in pop culture and their friends. It's become so normalized to vape that many people don't see it as a bad thing. But I think, I'll speak about that later, but I think it's changing now. And this, honestly, to me, it seems like kind of similar to what happened when cigarettes became very popular. You can see in this picture on the top left with Elijah Wood and Nicolas Cage. And this was at the 2018 Sundance Film Festival, where Juul was a sponsor. And you can also see that in the picture in the middle is a screenshot of a TikTok where Lana Del Rey, she, in the middle of her show, she said that she lost her vape and someone threw their own vape at her, right? And this went viral and millions of views and hundreds of thousands of likes. So you can see, like, even on the right side, the right picture, that's not an influencer or celebrity. That's just, you know, any typical person like me who decided, hey, I'm gonna just make a TikTok for fun. And it was about vaping and it blew up, right? So when things go viral like this and the younger generation looks at this and sees that there's millions of views and hundreds of thousands of likes, you go into comments and people are able to relate to it, start to think, oh, a lot of people are vaping, it must be okay. And then once people see this, they start vaping and their friends will start joining in because their friends are doing it too. So it's just a vicious cycle. So I want to talk about what makes vaping attractive to youth in comparison to cigarettes. So I learned something called barriers to entry in business class when I was in college. Pretty much it's obstacles that a company needs to like overcome when they enter a new market or industry. And I think it's relevant here too, right? Because the obstacles with cigarettes or the barriers to entry to cigarettes are a lot of these things where, you know, it smells, right? And leaves residue on skin and clothes. Whereas vaping, you don't see that. Taste is also an issue, whereas vapes have tons of flavors and good flavors like fruits and candy. And the stigma behind cigarettes, well, it wasn't there before, but now, you know, the younger generation hates it. That doesn't exist with vaping. But I think concealability and accessibility are two of the most interesting things that I've come to know as like a vapor. It's very small, leaves no smell, right? It's not obvious to other people that you're vaping. So it's easy to be concealed. So as a teenager, you kind of want that, right? Because you don't want your parents to know that you're vaping or authority figures to know that you're vaping. But concealability also allows for accessibility. With cigarettes, you know, you have dedicated smoking areas, and if you do it indoors, everyone will know. But vaping, you don't see that. So I had a lot of friends who would vape during class in their classrooms, even on planes, just pretty much anywhere, because if you can get away with it, then it makes it very easy. So I'll come back to this in a little bit when I talk about quitting, but I think keep concealability and accessibility in mind. And so the current views, I think there's a little bit of optimism because it seems like things are looking up. When I scroll through TikTok nowadays, a lot of young people are saying, hey, both influencers and just like normal people like me, they start to think, hey, maybe I should have never started vaping, or think, oh, vaping is stupid. You know, they're kind of changing the culture on it, where these TikToks on the screen right here, I just screenshots of them, and you can see even celebrities and just normal people saying, stop vaping, don't start vaping, you know, vaping isn't cool. And I think an interesting one is the one with like 4 boxes over there in the middle. That's when I just looked up vaping on TikTok, and everything is about stopping vaping, and all these TikToks are going viral. But this is completely different from what I've seen from 2018 to 2021. Back then, you know, people would post memes about vaping and it made it very relatable, like, oh, I lost my vape, I'm starting to freak out and all that. But now it's starting to become a little bit more negative. And I think a stigma similar to what you see with cigarettes is starting to develop. And also, when you're talking about sorry, I lost my notes. But okay, now I'm gonna actually just transition into quitting vaping. I think that quitting vaping is arguably harder than quitting cigarettes, just because of what I mentioned before about the concealability and accessibility. You're able to have it on hand all the time, right? So when I was studying for exams in college, I would be in my dorm room And every 2 minutes, I would just take a hit of my vape, and it's constant, right? So this eventually gets to the point where vaping becomes habitual and it's not cravings based, right? Like cigarettes are. And I didn't crave the nicotine. It was just more so the motion just became a habit, like second nature, right? And so when you think about quitting cigarette or quitting vaping, you're not only dealing with the cravings you have with nicotine, but also just the action of doing something repetitive like your whole life, right? And the newest trend that I've seen in terms of tobacco use are nicotine pouches, as you can see on the far right 3 pictures. I've also seen it in my friends. They all quit vaping to now do nicotine pouches like Zyn. And yeah. So just a little outro. I hope that my presentation was a little bit useful. I didn't have a lot of time to go into these details, and I feel like a lot of them could have been a whole separate discussions. I think it's important to consider the perspective of the youth, right? That's your target audience when 50% of them are using vapes. And when you're thinking about preventing them from using cigarettes or vaping and helping them quit, I think it's important to consider their beliefs too. Thank you.
There will be time for questions at the end for anyone wondering.
Hey, hi everyone. My name is Brendan Kernan. I'm a middle school health teacher. It's kind of nice to have people looking at me or at the screen versus, but feel free to look down at your phone or like crack a joke to someone. It kind of makes me feel at home teaching middle schoolers. So it'll definitely ease myself a lot. All right, so to start, for each grade that I teach, so 6th, 7th, and 8th grade, a main unit, part of our health education, is substance use prevention. So during this unit, each grade focuses on different core curriculum concepts that build upon the previous year. And each grade has its own set of state indicators used to develop a pathway for education and prevention. So this importance of substance use prevention unit, middle school students are at a very important development stage. Students experience significant physical, emotional, and social changes with an increase in vulnerability. Definitely makes teaching them a fun experience. This age group is particularly susceptible to trying substances due to peer pressure, curiosity, and the desire for acceptance. And a big part of that now is social media. Education on substance use prevention during these formative years can influence students' attitudes and behaviors towards substance use in the future, empowering students to make informed choices. Building resilience through prevention programs can equip students with coping strategies and promote resilience, allowing them to handle stressors without resorting to substance use. Addressing myths and misconceptions through fact-based education provides accurate information about the risks and consequences of substance use and helps to debunk any common myths that may glamorize or trivialize the issues. So for my 6th graders, our substance use prevention in terms of looking at like tobacco, nicotine, and vaping, we're describing situations that could lead them to use of nicotine products as an unhealthy coping skill, and then determine reasons why people choose to use or not to use nicotine products. So a big skill development is analyzing influences and self-management. So I focus a lot on the healthy coping skill aspect and recognizing that it can become a negative coping skill if it's used. So content for my 6th graders is linked to the Wellness Star. So it focuses on physical, emotional, social, and spiritual consequences. Students use various reliable sources of information to explain how nicotine use could affect different areas of the Wellness Star. Now for my 7th graders, this is where I dive into a lot more of like tobacco, nicotine, and vaping products. So it's identifying the physical effects, describing negative consequences, the positive alternatives. Again, that's more positive coping skill aspect of things. Explain why using nicotine is an unhealthy way to manage stress, anxiety, and depression, and then determine the benefits of staying nicotine free. So the skills developed are accessing information and advocacy, And then currently my 7th grade students are actively working on this. I just started this week with them. But it focuses on the content for 7th grade is the students being able to examine how vaping and nicotine affect the teenage brain. So I have a station rotation that serves as like research for them. So it's looking at a YouTube video that's looking at how vaping, like the hit your brain takes, CDC health effects on vaping article, a brochure about vaping, interactive website by NIDA, and then a NIDA article on how nicotine affects the teenage brain. So my 7th graders used this knowledge gathered in their research from the stations to then write a persuasive paragraph to a friend, convincing them to reconsider vaping. And then my 8th grade framework for substance use prevention is a little different. There's not as much focus on nicotine and tobacco products. We summarize the negative consequences of them and describe relationships between substance use and health risks, including unintentional injuries, violence, suicide, and sexual risk behaviors. Defend the benefits of being free from alcohol, opioids, nicotine products, marijuana products, and other trending drugs or substances. And the content in 8th grade focuses on more addiction in the brain, and the primary focus is medication and opioids, not vaping. So I do involve nicotine products and whatnot when I'm talking about the addiction side of things, but definitely with 8th grade, it's more focused around addiction, the brain, and then opioids rather than vaping and nicotine. And then the local health department has been a resource for me and the rest of the teachers. For information, they provide guest speakers upon our request to come in, talk to students about resilience and coping strategies and avoiding the use of nicotine, tobacco, and other substances. And then we had a training opportunity this past summer before the school year started on a session on nicotine updates for teachers. So we looked at more of nicotine pouches now because they're becoming more prominent. Not that vapes aren't going away, but those are definitely becoming more of a more prominent. So we're starting to look at that and how to involve that into our lessons. That's everything. Thank you.
Thank you both. That was amazing, wasn't it? Let's give them a round of applause. Thank you. Okay, we're open for questions for Dr. Bennett or any of our 2-star speakers here. There's a mic. Colleen has the mic. So if you just put your hands up, she'll bring the mic to you. Then we'll pass it on to the next person. Dr. Bennett, if you wouldn't mind just stepping up so people can remember they have to ask you questions too. Okay.
Perfect. Hi. Thank you for those great presentations. I'm Megan Moran, Johns Hopkins University. My question is for Mr. Kernan. I'm curious about whether you've noticed that there's any one particular piece of information or pieces of information that kind of really hits home with the students. I'm picturing the mind blown emoji where they're like, whoa, I never knew that. And what is really what are they really grasping onto in the lessons that you're teaching them?
I think a lot of it has to do with when they see how the affects their brain and the development going forward. And I think a lot of it has to do with the emotion point of thing, or they can see they may not be able to realize it now, but as they're going through middle school, very difficult time, they're growing and seeing how that emotional regulation piece isn't always there, and understanding that the use of nicotine and everything else harms that development. And then I think seeing that part really makes it click in their head sometimes. And I think it's a lot visual representation. I think they get more from watching a video or using an interactive website than listening to me talk all the time. They kind of get tired of that, I feel like. But
Thank you.
My question was for Austin. Was this curriculum in your school when you were in middle and high school?
Curriculum for
The
vaping.
substance abuse or curriculum?
No, so I actually grew up on Guam. So we didn't have a lot of like resources available in like other states do. So there wasn't any talk that, people would come in and do substance abuse talks and presentations. We didn't really have any of that.
Thank you.
I just wanted to thank you for sharing your story today. I think the courage that took demonstrates one of the barriers to coming forward to seeking treatment. And my question for you is, you talk about barriers to entry and the things that make it seductive and easy to start vaping and quit vaping, but what are those barriers to treatment? Like what things, factors do you see, especially in that college age crowd, when you were attempting to quit, that push people towards that health move?
Well, I think, in my case, right, it was my dropping grades, but when it comes to reaching out and asking for help and for treatment, I think people feel like there's a little bit of shame in doing that. And also most of the time they just don't want to quit, right? I think they see it as, oh, I'm a young person, I still have some time, right? I can continue doing this without, having any serious health risks. And even in my case, I decided that I was going to quit sophomore year, but then I took it very seriously my senior year of college, right? And so maybe it takes some time to just like mature a little bit and get a newer perspective, but also you don't really hear a lot about people quitting, right? So in my head at the time, I was like, why should I quit when no one else is quitting either? But I think it's becoming a little bit better now. I remember, I want to say it was like 2020 when the Truth Initiative, they started putting their ads out on like YouTube and TikTok. And I think that got a lot of people to quit. Because at the time I saw people dunking their vapes in water just to destroy it all and then recording it and posting it online. And those are getting, hundreds of thousands of likes and views and whatever. And so when more people see other people doing it, kind of have, like I said, like we're very impressionable people because of social media. And I think when you see others doing it, it encourages, others to do the same.
Thank you, Austin. I know Abby has a question. Who's next?
Hi.
Say your names if you don't mind. Just state your name.
My name is Jen Kirshner from the Baltimore City Health Department. This question is for Dr. Bennett. Hi. So we've done a lot of work with behavioral health providers in clinics who serve women and women with children in the city. And one thing we hear, we refer them to the BH2 trainings, and they're very excited to have someone come out and talk with their clients. But one thing we noticed is the impact of the built environment of the centers, as well as the fact that the staff are also smoking or vaping. And I'm wondering, does your training or follow-up technical assistance get at some of those more tangible factors?
Yes, when asked. So our standard training, we're pretty full. But I have had follow-up from programs, especially ones that focus on substance use disorder treatment, and a couple of consultations with program directors and administrators who want to try and change some policies around tobacco use in and around their building and on their campus. And a lot of times there's people want to make that change, and we talk about it, and they just meet a lot of resistance. I think there's a fear, maybe two fears. One is that the people who they're serving who smoke will not go there because they won't be permitted to smoke. And, we have some evidence that people are looking for treatment programs that don't allow smoking, because that gives them an opportunity to work on all their substance use issues, including smoking in a smoke-free environment. But that seems to be a fear. And then that people who, right, sometimes there are staff people who smoke, and that making policies that could affect staff, is not an easy thing to do. So I don't address that in the larger training just because I'm trying to get everybody on the same page about treatment. But I am open to talking about how to overcome some of those barriers. I think that one of the easiest things we can do, and these are two things that I do stress in the large training so everybody hears them. First off, tobacco treatment is not an educational problem necessarily. I mean, most people who smoke, whether they're coming to a program for a health issue or they're providing services in a program for a health issue, know that smoking is bad. And most smokers have it on their to-do list to quit. So because of that, whether you're a person coming for services who smokes or you're a staff person who smokes, we start with the same basic knowledge, which is fine. And it's hard for anybody to quit smoking. So it's actually a place where people can come together. It doesn't have to be, well, I do this, and so I can't talk about it. You do it. Yeah, it makes you a perfect person to talk about it. So we talk about that. And then we talk about how any program is a good place to have conversations about tobacco, even if somebody's not ready to quit yet and the policy doesn't match up with that. So trying to have a conversation throughout, if your work with somebody, even if while we're waiting for the policies to catch up.
Thank Dr. Bennett.
Okay.
Abby's standing. Okay,
Hello.
so that'll be the last question.
Okay.
Abby, go ahead.
It's like,
What? Me more.
Oh.
Okay, so I want to give everybody a break, okay? So it's 10:30, okay?
Hello,
Go ahead.
everyone.
Abby,
Hello. Yes, thank you. Hello, everyone. Abby Kalan from School of Public Health, Department of Behavioral and Community Health at College Park, UMD. Actually, this first off, that was great presentation, all of you. And it's really hard for middle school to have that, like the prevention program explaining to them. I can tell that. And this is a comment about the work that we actually presented last week, 2 weeks ago, at Society for Research on Nicotine and Tobacco, on why kids start vaping and continue vaping. And some of them that you starting and continuing was different. Starting was more about curiosity and family and friends. The continuation, family and friends was there, but continuation was more about the nicotine buzz and also stress and anxious. And we used 9 years of national data to show this in that conference. And this was very interesting that they mentioned that very low person, that was self-report, used that to quit cigarettes. And the flavor as a reason to start was decreasing over time from 2015 to 2023. And that was just a comment to mention. And thank you again for your presentation.
thank you, Abby. We have 2 more questions.
Good morning. My name is Tamara. I wanted to thank Austin for sharing your lived experience because I have a 16-year-old. But my question is to Brendan. I wanted to know if the conversation about tobacco is easier had classroom setting versus like at home with the parents, or what advice and suggestions do you have for parents who have this issue with the young people?
It's a good question. I think from my standpoint, just being in the classroom, I think it's more on like the education side of things. I don't know if that helps to like reach certain parts of it. But in terms of like the conversation at home, I mean, there's great resources out there that kind of like the Truth Is campaign with like YouTube videos and things like that. I think those really help reach like the younger, like the youth in this time frame, because it's it's going towards their interest. Like rather than listening to someone talk and lecture and go on and on and on and on, like they have something visually in front of them that allows them to view things that we're trying to reach them. But I feel like it's easier said than done for me, like just being in the classroom, because they kind of have to sit there for 45 minutes with me and listen. And I understand that it's difficult to go home and do it, but I guess my suggestion would be trying to like integrate some of those like Truth Days campaigns or whatnot, like some sort of visual component that applies to them, like social media and things like that definitely has a big impact on them.
Okay, thank you.
Hi, thank you guys both so much for this presentation and the courage to get up and talk about your vaping story. Congratulations on your quit. So I'm Susan Wally. I'm a pediatrician at Children's National, as well as Dr. Kapunen, and I'm a certified tobacco treatment specialist and was the former chair of the American Academy of Pediatrics section on nicotine and tobacco, and love the previous question because we as pediatricians do know that we have an impact, and parents and siblings and friends have such a big impact, as well as teachers. So my question actually was, though, when we talk about the built environment in schools, we know that oftentimes in the process of, supporting a middle school or high school student or even college student that has a nicotine addiction, sometimes the actions that are taken might be very punitive, like suspension from school, and not towards, this is a medical illness and helping provide addiction therapy. So just wondering from the middle school teacher here, if you're aware of what happens when a middle school student is found with a vape, and we've heard progressively, maybe the first time it's taken away, but the second or third time that student might be suspended. So that's, thank you again.
I know that, like you said, like initially it's definitely like confiscated and taken away, and there might not be like a suspension first off. I know they are like put into like it's like a Saturday school, like a tobacco and nicotine education class at one point in time. But beyond that, I'm not totally sure what the next steps are, like moving forward, like if it happened multiple times. I know it's like taken from them. It might be, in school suspension for the day, that Saturday school class and things like that. But beyond that, I'm not totally sure what the next steps are, because it goes up the chain of command past me at that point in time.
Right, thank you. So unless there is one more burning question, there is. Right there. One more question. So thank you both for so many answers. So, we think there are about 5,000 suspensions every year in Maryland for vaping. Those were some of the data we saw, which is a lot of kids. We think there's got to be a better way to teach them or train them. Yeah. Okay. Please state your name.
I'm Dana Thomas. I am from Riker, Baltimore. I also work for Baltimore City Schools just as well, not too long ago. But my question is for the Gen Z person. I forgot your name. I heard you say you stopped vaping and it's hard to get treatment as far as like shame around treatment. But a lot of the times it was social media that impacted as far as everybody kind of, doing away with wanting to quit vaping. What do you think that the schools, my question is, what do you think that the schools can do to kind of impact students as far as seeking out treatment or just, trying to quit vaping?
In terms of what the school can do, I think, or just in general, schools, I think when you start to punish students for vaping, it's a little bit counterintuitive. I've never seen, any of my friends quit from getting punished. But I think when you help facilitate it by, just encouraging them, rather than telling them, oh no, vaping is bad, vaping is horrible for you, instead of coming in from a perspective of like judgment, being able to help them set goals for themselves and also refer them to people who, can help them quit, even with like medications and different strategies, I think helps. And also, like peer support groups are a thing in schools that happen a lot, right? So, in my case, in college, I would have loved to like form a peer support group and help, other college students quit. I think that could be very beneficial too, right? Because it's not an authority figure coming from it, coming from like the perspective of quitting, right? It's someone who it's like your peer. So I think that might have a bigger impact than, having like a teacher come up and tell them, hey, you need to quit vaping. But yeah.
Everybody, it's great to be here with such a great group. My name is Megan Moran. I'm an associate professor at Johns Hopkins Bloomberg School for Public Health. Before we get started, just a couple of disclosures. I've served as an expert witness in litigation against the tobacco industry. And the work that I'm presenting has been funded by a variety of wonderful sources, including the NIH, the Burroughs Wellcome Foundation, and the US FDA, including some internal funding from Johns Hopkins as well. Good, thank you. Also, a thank you to two great resources that you may or may not know about that we rely on in our work, the Trinkets and Trash Archive at Rutgers University and the Stanford Research into the Impact of Tobacco Advertising, or SRITA, archive, both of which are really excellent resources for finding tobacco advertising online if you're ever in need of kind of examples for presentations or sessions that you are doing. Thank you to my team. We kind of informally call ourselves the Target Collaboratory because we're interested in how tobacco companies target different populations. We have a group of folks ranging from master's students, undergraduate students at Johns Hopkins, all the way up through faculty. So what I want to talk about today is what the tobacco industry is doing to target young people and also to mislead consumers about the relative risk of their products. I'll talk a little bit about the context for this work, FDA's authority to regulate tobacco advertising. Then I'll show some of the research that we've done in the area of youth targeting and misleading advertising claims, and then kind of summarize with some takeaways of what we might be able to do about it. So the FDA and tobacco products, just as a brief refresher for folks who may already know this or not know this information, the Tobacco Control Act granted FDA the authority to regulate the manufacture, marketing, and distribution of tobacco. In the area of tobacco marketing, there's two kind of pathways that this can happen. One thing that we're really interested in is FDA's interest in kind of preventing tobacco use by young people. And so here we're really thinking about people who are aged 20 and younger. And then also FDA's ability to regulate tobacco marketing that is explicitly or implicitly misleading to consumers about the risk of that tobacco product. So claims that the product is potentially less harmful from than other products or less addictive than other products would be encompassed here. Just to give you some background on why we need these regulations, the tobacco industry has a long history of targeting youth. I'm not sure if you remember when this type of advertising was incredibly common. I mean, when I was a kid, Joe Camel was like this cool dude. And he was everywhere. And so you can see some of these tactics are now banned. We don't have We don't have Joe Camel anymore. This type of explicitly sort of branded merchandise, similarly gone. And then when it comes to misleading consumers, we see this has been going on, for decades and decades as well. So tactics including descriptors that cigarettes are light, low tar, mild, smooth, design features that mislead consumers. So like a longer, skinnier stick misleads people into thinking that the cigarette is somehow safer than a more traditionally shaped cigarette stick. And even colors, the use of light blues, silvers can lead people to think that the product is less harmful. So given this context, we're interested in what the tobacco industry is doing now so that we can hopefully produce evidence to inform regulations and also educational efforts as well. We know that the tobacco industry, beyond what I just showed you, uses a range of other tactics that appeal to youth. So here's some advertisements within the past decade or so that feature things like themes of rebellion and risk-taking, themes of independence, young people, the use of celebrities, connections to sexuality and romance and so forth. These have all been kind of identified as things that appeal to youth and make the product more attractive. But the question is, youth culture is constantly changing, the tobacco industry is constantly changing, and the media landscape. If you think back to, gosh, what was it, like just over 15 years ago when the Tobacco Control Act was passed, right? Social media has completely exploded and evolved. And so it's really a moving target for us, right? Do you think about what was cool with young people, I don't know, a year ago, maybe even like 6 months ago, trying to find Mr. Kernan, who probably knows about the ever-changing interests of youth, right? Excuse me, it constantly changes. And so it's really hard to kind of make these strict regulations where it's like, well, you can't do this and you can't do that, because what youth are interested in changes and the tobacco industry is able to evolve and appeal to youth. So in an attempt to try and keep up with this, our team engages in this kind of 360 approach where we first surveil tobacco advertising. We collect as many tobacco advertisements as we can find, and we code them for a variety of content. We conduct surveys where we show people these advertisements and get their perceptions. And then we move to a more kind of tightly controlled, randomized experimental study where we really try to see causal effects of specific advertising tactics. To give you a sense of the scale of some of the content coding that we do, we've coded at this point over 10,000 ads since like 2015, I would say. We get our ads from a variety of sources. So we work with a market research firm that basically just like they collect all sorts of advertisements, and we get the tobacco advertisements that they collect. We use the archive that I mentioned at Rutgers University. We do our own data collection, capturing social media posts. And then we've trained, dozens of coders at this time, students usually, to characterize in a standardized and rigorous way content, including claims that the companies are making, opportunities to engage with the brand via sweepstakes or signing up for social media or direct mail, different types of product features that are being highlighted, various themes that are used in the advertising, and promotional features like coupons and discounts. So I want to first talk about one study that we did where we took information from this content analysis and we combined it with data that we collected from a survey of 18 to 20-year-olds in which we showed them 6 different advertisements, 3 e-cigarette advertisements. And we had them basically tell us, like, how much do you like this ad or not like it? Does it generate any curiosity about the product? Does it make you interested in using the product? And then we merged all of this data together and conducted some analyses to try and figure out what were the common features to the advertisements that young people liked most. And so what we found was that among e-cigarette advertisements, should be no surprise, when flavors were featured in the ads were more appealing. Use cues, so kind of featuring the product in use or maybe being held by somebody, increased interest in using the product. Claims that the product was easy to use made people curious about it. Requests to kind of engage via social media were something that generated liking of the ad. And then interestingly, some of the advertisements had youth restrictions that this product was only for people 21 older or adults. This also increased interest in using the product, which could potentially speak to like a forbidden fruit kind of effect. And then among cigarette advertisements, only one thing that we examined decreased appeal. That was claims that the product was enjoyable. Sweepstakes, where people could register for a chance to win a free gift or a trip, increased appeal. Free gifts similarly made people interested in the product. Rebellion claims as well. And then socialization, so featuring people, usually kind of like smiling in a group, maybe at a party, at the beach, something like that, increased appeal as well. To give you a sense of just what some of the ads look like, these were our top 3 most liked ads product. And in the next slide, as a contrast, I'll show you the least liked ads. And so the first thing that most people notice when I show these 2 slides in succession is the difference in color. We did not code for this because it's incredibly difficult. We, in like 10 years of doing this, have never been able to get like a reliable capture of color. But our qualitative assessment indicates that this is clearly something that's probably also contributing to the appeal as well. So in our next study, we then conducted a randomized controlled experiment where we explored some of these tactics to try and get a better sense of the causal inference here. We know that when the government, at any level tries to regulate tobacco marketing or the industry in any way, there's usually a lot of pushback and, the industry will sue. And so we want to make sure we have the best evidence possible that can stand up in the court. So here we conducted an experiment where we randomized the presence of 3 tactics. The first was sweepstakes. The second was imagery of flowers or plants, which was something we saw in a lot of advertisements. And the third was eco-friendly language, so that this product was organically grown or all natural and so forth. To give you a sense of just what some of the ads with and without these tactics look like, you can see here's one with a sweepstakes and without a sweepstakes in that black square on the bottom. Flora imagery. We did this across a variety of brands, including a non-US brand to try and mitigate any brand familiarity effects that we would otherwise see. Eco-friendly language. And all of these are real advertisements with language taken from actual advertisements. And so what we saw was that Flora had the most compelling effect on appeal. We saw a slight effect for sweepstakes. You can see here, it didn't quite hit statistical significance. And eco-friendly language didn't really do much at all. Now, to take this kind of a little bit deeper, we conducted a qualitative case study of a less known tobacco brand called Hestia. I'm not sure if folks are familiar with this brand. There's a great New York Times article if you're interested. I have it on the headline right here that you could Google. It was founded in 2010. It doesn't have a huge market share. It's not available nationally. It's really interesting as a case study of a cigarette brand that's trying to make cigarettes, quote, cool again. So we conducted a qualitative analysis of their Instagram posts and their Twitter or X posts between 2022 and March 2024. And I just want to show you some of the things that they're doing because I think we need to keep an eye on this and make sure that other tobacco companies are not kind of using similar. So one thing they did was engage influencers with or without kind of like an actual collaboration. So in this post on the left, you can just see they essentially like found a picture of this person smoking on a party website called Cobra Snake and reposted it. Kind of trying to establish like that norm and like emphasize that smoking is maybe that cool people like this young woman do. And then similarly with these women on the right, there's a lot of connections to like memes or politics, things like that. Again, where they either are creating this themselves or just reposting the content. We see a lot of reposts of celebrity smoking. Again, unclear if this is an actual photo, if this is photoshopped by the company, if this is a paid relationship, which doesn't necessarily matter at this point because the post is out there. That's Pete Davidson from Saturday Night Live, or formerly SNL, in case you were wondering. Co-opting cigarette advertisements. So like Joe Camel is kind of making a comeback here in these ads. Making implicit health related claims. So you can see here, they repost somebody asking what's the healthiest cigarette out there and say hi, implying that it's us, we're the healthiest cigarette out there, without actually saying Hestia is the healthiest cigarette out there. Or reposting this kind of content in the post on the right, where people are kind of, this person is positioning cigarettes as something that's okay because the alternative is apparently heroin. And then greenwashing, lots of greenwashing connection to the environment, which, as I'll discuss in a minute, is known to result in perceptions that cigarettes are safe. Engaging with other social media accounts, which is a great tactic. If there are any kind of social media managers in the audience, you know that the engagement with other accounts and people who follow your own account is key to building an audience. So when we put all of this together, ranging from kind of like the bigger quantitative studies to this very qualitative case study, we're witnessing the tobacco industry engaging in numerous youth appealing tactics. And this can be really difficult to detect without intense research and surveillance. And I'll kind of note that we didn't even get into those sort of paid relationships between the tobacco industry and influence. There's a great report from Campaign for Tobacco-Free Kids on this. They just did like an incredible amount of kind of like forensic research following the money and the relationships and the posts. But it's really intense work that requires time and expertise. So it's quite challenging. And it's also really hard to discern just at first sight, especially for those of us who are maybe not, 18 years old, what is or isn't appealing to youth, right? Like, I think there's certain things that we might look at and say like, well, like, sure, like a cartoon, youth appealing. But we're finding that there's other things like pictures of plants and flowers, which are appealing to youth, which at face value, I never would have suspected. But young people find that attractive. So we really need to think harder about what the industry is doing and what we can then do to respond. So the next line of research that I want to talk a little bit about is how the industry misleads consumers about the purpose of their product. So you might be familiar with this brand, American Spirit. They previously used the terms additive-free and natural to describe their products. FDA restricted use of these terms, that's great. But you can see here, right? Here's two ads that use the terms. Let's block them out. I don't think we're fooling anybody, right? Like the imagery, the other language is still conveying at face value a very similar message. And you can see here how pre and post that agreement, the company just sort of was like, okay, we'll stop using these terms. And now they're using completely different yet with similar meaning terms, tobacco and water instead of additive free, as an example. You can see an image of it here. So we wanted to know, well, does this look a risk to consumers? We did another randomized experiment. We showed people one of these images. So these are all different ways of advertising American Spirit, or in the bottom row, this is a Canadian brand again to get at that brand familiarity effect, with the old language, with the new language, with different combinations. And so what we found, this is the new ad in orange. What we found was that it's less likely to convey that the cigarette is safer than the old ad. Like, that's great, bit of an improvement. But it's more likely than an ad with none of that language. So it's still misleading consumers into thinking that American cigarettes are somehow safer than any other cigarette on the market. And when you look at an additive-free descriptor just by itself, it's statistically identical. We looked at this more broadly in a study that actually, this is an old citation. It was just published in Nicotine and Tobacco Research here. But we did more greenwashing. So we have an ad. This is what it looked like. It was just kind of like straightforward language. This is a high quality product, blah, 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 blah. Bottom, we have some pictures of the leaf. We have some language about how friendly the product is, so forth. And we see here that when we have greenwash text and a pack, or excuse me, and a plant image, that people think that the product is safer than other cigarettes, that it's less addictive than other cigarettes. And just to kind of compare an ad with like none of this language or imagery versus an ad with all of it, you see these shifts. So like you see, if you look at the top right, all of these people who with the kind of basic ad said this product is a little less harmful, right? It's barely anybody. And then you see when they're given all of that information, like an incredible number shift to think that it's less harmful. So this evidence is indicating, right, that the industry is misleading consumers, but in a way that's very sneaky, because they're not explicitly saying that this is a safer product. They're simply just kind of conveying that it's organic, it's natural, it's eco-friendly, and people associate that with health. These tactics are commonplace. And so is again very challenging to regulate because, as we saw initially, you restrict the use of one or two terms, and the industry just has an incredible arsenal of other tactics that they can use. So to summarize all of this, presumably if we restrict or reduce youth-appealing tobacco marketing, it would result in lower rates of youth tobacco use, right? We know that there's a causal effect of this marketing on youth tobacco use, so we get rid of it. Presumably, we would see less tobacco use. If we reduce misleading claims, it would presumably also reduce tobacco use, and maybe even help with the safety claims. We know that sometimes people switch to a cigarette that they think is safer, rather than quit completely. And we know that no cigarette is safer than any other. But there's a real question of like, so what do we do? Like, do we just like keep sending out these warning letters? You can't do this, you can't do that. And then the industry says, well, we'll just shift it slightly. It complies with the letter of the law, but not the spirit. I would argue that content neutral bans are something that we as a community really need to be advocating. So this would include things that we already like widely do, right? Like restricting tobacco advertising near schools or other places where young people spend time. But also could be expanded to only allow text and imagery that is absolutely necessary in the advertisements, restricting the use of colors and things like that. I also think that we need to better educate young people about the tactics the industry is using. And so I know that the Truth Initiative was mentioned earlier. They are doing a great job at this. But I think there's a lot of other contexts where we can kind of talk about like, this is what the industry is doing. And this is why they're doing it. They are trying to make you think that this product is safe. They are trying to make you think that this product is attractive or appealing. and really widely publicize this. So yeah, thinking about this, thinking about restricting tobacco use more broadly, flavor bans, geographic restrictions, fleet bans on tobacco sales are also things that would be very helpful in this context. So thank you very much. My email address is here if anybody wants to discuss further. Thank you.
Good morning. I was, if you'll allow me just for a minute, I was reflecting on how the first time I ever presented on this project was at this conference, I think 3 or 4 years ago. And it's very fitting that this will be the last time I will be presenting on this topic as I'm transitioning out of leadership for this project. Dr. Devlin Jackson will be taking over, so hopefully she'll be here next year. But I was reflecting on how much we have done in those 4 years, and I'm excited to tell you all about where we are as we go out into the community. First, I want to just spend a minute talking about who we are. So I'm currently the director of the University of Maryland Prevention Research Center. We are a CDC-funded center. We're currently in a no-cost extension year. We are one of previously 26 funded CDC prevention research centers in the country. These centers are designed to identify a chronic health condition and a specific population, and then work together with and in a community engaged strategy to tackle that chronic health condition with that population. For us, we are an interdisciplinary team of health researchers, and our focus is on LGBTQ health equity broadly. And we house a lot of different projects under that initiative and mission, one of which is the one I will talk to you today. And as part of this work, the Prevention Research Center Network is very interested and pushes science translation. And so a lot of our work is done in service to developing training and technical assistance to improve mental health and behavioral health care for LGBTQ populations. For this particular project, we've been working very closely with the Maryland Department of Health, the Center for Tobacco Prevention and Cessation, and we are tasked with trying to reduce tobacco-related health disparities and to promote culturally appropriate tobacco prevention and cessation interventions for our population, which is Black and Latina LGBTQ youth between the ages of 15 and 21. Our main area of focus are the 2 counties that flank the University of Maryland. So that's Prince George's and Montgomery counties. That's where we spent most of our time, most of our outreach, and now most of our dissemination and engagement. We are at a point, I think, in our project where we're expanding that and building partnerships in surrounding counties and hopefully across the state as we grow. We center a ongoing community-driven strategy. We have two parallel community advisory boards, one that we conduct in English and one that we conduct in Spanish, given our 2 focuses, there are 2 populations of focus. And we work with them very closely in an ongoing and iterative fashion, along with our community stakeholders and partners, to develop a tobacco prevention and cessation communication, what we're calling a campaign, materials, resources, and other training and technical assistance options that folks can engage in to be able to support tobacco prevention in this community. This is our team, which has changed over time. It's grown quite a bit over time. We engage undergraduate research assistants, graduate research assistants, Masters of Public Health students, PhD students, an assistant all the way through full faculty. We have folks who do health promotion, basic science, translation, health communication, and we have worked collectively for 4 years and have added community outreach partners into our fold to be able to ensure that our work continues to be informed by and engaged with our community partners. I want to spend a little bit of time talking about why we do this work. As someone who studies LGBTQ populations and LGBTQ youth day in and day out, it's pretty widely known, but there are very stark disparities for LGBTQ youth and young adults as it relates to their tobacco use and e-cigarette use. These are visually appealing data from 2016. The rates have not really changed. It's pretty consistent with what we see today for lesbian, gay, and bisexual females and transgender youth relative to non-transgender youth or cisgender youth. We see pretty stark differences in cigar use, cigarette use, e-cigarette use, and use of one or more product. And even with the most recent YRBS, we see that both nationally and within our state. As with many health disparity populations, this increased risk for tobacco and e-cigarette use, the onset, progression, and maintenance of that use is really rooted in social determinants, including stigma and minority stressors such as victimization, bullying, and rejection, and also targeted advertising, as Dr. Moran was just talking about. So we have a very well-established literature that showcases how experiences of what we call minority stress at the individual, interpersonal, community, and social level, including laws and policies, school environments, family environments, peer victimization, bullying, and ostracization, and the internalization of those feelings, right? That increase stress, poor mental health, and maladaptive coping strategies such as nicotine and tobacco use are a lot of what has been attributed to some of the corresponding and causal factors for increased risk for tobacco use and the maintenance of that use through young adulthood and into adulthood. Again, with targeted advertising, LGBTQ communities were one of the target communities in Project SCUM, dating all the way back into the 1980s, starting in the Castro district of San Francisco, and have perpetuated all the way through into today. You oftentimes see big tobacco sponsorship, giveaways, and the like at pride events in LGBTQ bars and spaces, and this continues on for today. It's also really important to note that while we do see some shifting in the use of particularly combustible cigarettes over time among young people, trends for LGBTQ youth in particular are headed in a different direction. So this is Healthy People 2030 and another visually appealing trend analysis, although this is not the only one to do this. There are several that have been published now, including by our team. That really showcase that the rates of e-cigarette and tobacco use for LGBTQ youth, in particular, the disparity between heterosexual and sexual minority youth has both been maintained over time. That means it's not shrinking, and in some cases, it's actually getting wider. So while cigarette use may be decreasing for heterosexual and cisgender youth in their use of e-cigarettes or combustible cigarettes or other products with nicotine, we tend to see that we're not seeing that same level of decrease in LGBTQ populations. So it remains a very important issue to consider heading even in contemporary cohorts of young people. And that's increasingly important when we consider that the percent of youth who identify as LGBTQ youth is on the rise. So trends in LGBTQ identification by generation, this is some data from Gallup, really showcase how more with each progressive cohort, more people recognize themselves and come out as LGBTQ. Ergo, a larger proportion of the population is experiencing these social determinants in ways that increase risk for tobacco among larger proportions of young people in contemporary cohorts of adolescents. And so when we consider that 1 in 3 or sometimes 1 in 4 adolescents today consider themselves to be LGBTQ, that increases our preponderance of people who are vulnerable to uptake and maintenance of tobacco use across adolescence and into adulthood. And when we think about the compounding factors of other forms of stigma, discrimination, and social determinants, including built environment, neighborhood, LGBTQ communities are not the only communities that have been targeted by big tobacco. Black communities, Latina communities, communities that have been more disenfranchised and marginalized. We know the data show that they are much more exposed to tobacco advertisements. So the confluence of these factors of being both Black and LGBTQ, Latina and LGBTQ increase risk in a way that's compounding. And that is really what kind of drives us to this work, what motivates this work, and why we continue to do this work when we consider contemporary cohorts. So we have been working on this project, like I said, with the Maryland Department of Health to really try and investigate and address tobacco uptake with LGBTQ youth and young adults in these 2 counties. In the 4 years since we've began, we have conducted comprehensive literature reviews to try and understand what are currently best practices for tobacco prevention efforts with these communities. There is not a lot, to be honest. We published a scoping review on this. There's very, very few guidances on how to engage in culturally appropriate communication strategies. We conducted community health needs assessments in our counties, built relationships with and had conversations with key informants. We maintained a community advisory board over the life of the project. We participate in pride events and do ongoing community outreach and networking. And we've built, I think, pretty strong relationships with our local departments of health to be able to build those networks and to share this information and resources, which I'll share with you in a minute, among many other things. And what we learned as part of this process, starting all the way back in our first year, was that yes, in our counties, even in our counties and even in Maryland, LGBTQ youth and young adults are disproportionately using tobacco and ends products. In our counties, Black and Latina LGBT youth and young adults themselves, through our conversations and focus groups and community outreach, perceive that tobacco use and e-cigarette use is a problem within their community. They recognize that. That's not necessarily a surprise to them. LGBT, and that one of the biggest things I think was a learning opportunity for us is that folks who serve LGBTQ young people in their counties don't prioritize tobacco prevention and resources. This is not a high priority for them. They're working on housing, they're working on food security, they're working on school engagement, they're working on a lot of other factors. And when we ask, what are you doing around tobacco? They really honestly say, nothing. And that was a really big eye opener for us, because then it becomes less so how do we help you, and it's how do we get you started? And those are very different places to start. So we, taking in this information, really as a team kind of thought through what is our approach in the next couple of years. And so what we identified is that we needed a low cost, low burden strategy for organizations to incorporate tobacco prevention information and resources into their everyday work environment, because they didn't have the capacity, they didn't have the resources, and they didn't have the funds or time to be able to do this at large scale. And so we thought we could take up that capacity building effort. And what we did was develop an effective communication strategy and communication campaign, what we call Live in Color, excuse me. This is a bilingual communication campaign and resource development project. It's a English and Spanish bilingual. And we really started from this idea where we're going to create a brand. We're going to do some of the basic research to try and develop evidence-based strategies to be able to speak directly to these communities in a way that is culturally appropriate, age appropriate, that and is able to provide them with information, education, and resources so that these organizations can use those materials, put them in their built environment, put them on their website, engage in social media, so that they don't have to do that work. So like I said, this is an English-Spanish communication health materials campaign that we are, our direct service link is through service providers. We don't work directly with young people. Our goal is to help service providers to build the capacity within their organizations. Our audience for these materials are Black and Latina LGBTQ youth and young adults ages 15 to 21. We integrate best practices in health communication, really centering community needs and community perspectives. As Dr. Moran was talking, young people's language and what's popular changes minute to minute. And so we're really cognizant of that as we're developing our resources. And what we've been able to do over the course of the last several years is to develop, and you'll see some of these on your table right now, print and digital materials for prevention and quitting. This includes a website for organizations to be able to go to seek resources and support, a resource list that we've shared with you all. We are currently finalizing our toolkit, which I'll talk about in a minute. We have rack cards, we have digital print materials that people can use on social media. All of that is free and available on our website. And we're in the process of developing training and technical assistance efforts to be able to support the use of those materials in community-based settings, among other things. So this is hot off the press. We are about to launch our toolkit. It's been a labor of love that we've been working on for over the last year and some change. It really is broken down into these 4 sections. It's, like I said, the audience for this toolkit are folks who work in community-based organizations and who are in departments of health. And it's really to kind of outline the purpose of the toolkit itself, like why does the toolkit exist? our messaging materials, and a slew of guidances on how to use those in a way that centers best practice. We talk a little bit, like I did previously, on the unique challenges of tobacco in the Black and Latina LGBTQ youth and young adult community to kind of gather buy-in and interest about why this is a worthwhile endeavor for organizations who might not already be serving this community. And we are with an eye towards sustainability. Our last section really focuses on how LGBTQ organizations and organizations working with this population can really build a network, a sustainable network of partners, so that, you know, if we cease to be able to continue to do this work in the future, they themselves have a built-in peer network of support to where they can continue to do this work on into the future. So like I said, part of our guidance is we want folks to be able to understand how to use these materials in social media. We're really interested in folks being able to put these resources and information on their website, to be able to navigate conversations about tobacco use with their clients and community members. A lot of our conversations with folks who are working in LGBTQ serving organizations, we're talking about how they don't even know how to start that conversation. And so we have some guidances around that. General communication about tobacco prevention, smoke-free events, smoke-free spaces, tobacco-free spaces, and more. So that's kind of all within that guidance and that toolkit, along with a very large compendium of print and digital materials that folks can use as they like. Here's some examples. Like I said, there's some rack cards on your table, but here are some of the digital pieces that we've developed and tested. So let's be real, being Black and LGBTQ isn't always easy, but it's so damn beautiful. You can see there the really the centering of the community, the speaking to the community directly, the visual imagery, the language. This was all considered by our communications team in the development, and through multiple iterations of feedback from our community advisory board were refined and then eventually tested. And I'll share those test results in a minute. So here's another one, trying to give some information, trying to correct the idea that tobacco and any cigarette use is a stress reliever, and trying to combat that misinformation in a way that might gain folks' attention. And then here's another one. This one's a little bit more direct. Some of the early feedback that we got in our development of these materials is how off-putting rainbow washing content can be, right? So if you notice, we don't have like the more traditional rainbow colors in our imagery. It's a more subtle connection to the community, and that is because both in other studies and in some of our formative work, that rainbow washing approach, where you're kind of just throwing a lot of rainbows on imagery, is kind of off-putting for some of the community. And so this is about as direct as we get in that regard. So we've done some preliminary message testing. We conducted a panel study of our core age group and populations through Sentiment, which is a national panel. And the preliminary results look very promising. We see no differences in personal or cultural relevance or ad likability between the messages that we tested, which I believe were about 8 different messages, and they all had a ceiling effect, reporting on average very likable or very relatable, very relevant. We did find a slight preponderance of liking among Black participants in terms of message strength and personal relevance overall relative to our Latina subpopulation within that sample that we've taken into account. But overall, they're showing us that these messages are relatable, culturally relevant, and speak to our population. And like I said, the rack cards and resource guides are available on our website for anyone who would like to access those. The toolkit should be ready imminently. So here's some examples of our rack cards. One of the things that I really love about our rack cards, our communications team was really clever. This is they're two-sided, and that we have our kind of core message on the front, but on the back, there's this interactive strategy. And this was something that we had kind of talked through as a way for service providers to kind of have a tool to where they can kind of have that conversation and kind of walk through, like, you know, decide what will help you quit. So kind of thinking through, like, so you kind of share that you're interested in quitting or cutting back, like what will help you do that? It kind of helps them get them through some of those stages of pre-contemplation, contemplation. It's something that we can pass out at Pride events and have conversations with folks about. And it just kind of makes that rack card a little bit more interactive and a tool for the service providers who themselves don't often have these conversations with the clients within their organizations. Here's another example. It's a different backing on that card, where we kind of give them tools to stay tobacco or vape free, right? So like if someone asks you, you say, I don't vape, thanks. So just trying to also give them some strategies and tools to not, for the folks who are using products and want to quit, but also those who aren't using products and may want some considerations of how they might be able to say no. And it just kind of takes the burden of that off. And then I think these are on your, might be on the pages, are on the tables as well. These are informational and resource pages that we've developed in English and Spanish. These are both state resources and national resources, including call lines. And because of our population of interest as young people, text lines, because that seems to be a much preferred strategy. And so this is something that we take out with us that folks can just put in their waiting room or in their offices, so that school counselor offices, social work offices, to be able, so folks can pick them up and get resources as needed. This is just one example of, or two examples of the guidances that we offer in the toolkit. So we have on the left there guidances for using key messages and materials. We know that a lot of these organizations do not have a communications trained staff member. They're really kind of navigating social media and communication on their own, on the fly. And so we just wanted to kind of give them some like best practices, some tangible resources so that they can engage in a way that garners interest and engagement. And then like we said before, the kind of feedback that we got around how do we even start to have these messages. Our team developed guidelines for having conversations about tobacco prevention and quitting that kind of walks them through a logic model about how to have these conversations with their clients when they otherwise might not. So we are currently heading into our dissemination phase for our toolkit. We've been distributing our materials for quite some time now. And we've been giving them to community organizations in Prince George's, Montgomery counties and beyond. We're slowly moving into Howard and Frederick counties. We have some engagement with a major LGBTQ center in Baltimore that's kind of budding. And so we're kind of getting out of our comfort zone there a little bit. We're really prioritizing organizations that serve LGBTQ clients. These are folks who have either longstanding reputations or have been able to build a space in where LGBTQ young people feel comfortable going and engaging in services, because we feel that this is probably our best avenue to be able to reach this population. But we're also really interested in working with and training departments of health on the use of the toolkit so that they can also share those within their communities. And you can get in touch with us on our website if you're interested in engaging in those trainings once they launch later this spring. We're developing and delivering TA and training specific to these items and other policy systems and environmental changes that we'd like to see happen within organizations specific to tobacco prevention. And that's in the works. And like I said before, we're really keen on building a strong network of folks. These LGBTQ organizations aren't really working with county tobacco folks. They aren't really working with other or have resource linkages to folks who are doing tobacco cessation support. And so we're really trying to link them into those networks so that they don't have to take that on themselves, that they can refer those young people to those services and continue to stay within their mission for the work that they currently do. I just like to share this because I know a lot of folks who might be new to doing this work with this population might be looking for information and resources. The National LGBTQ Cancer Network, which until I think last week was funded by the CDC, has a resource online that you can access hopefully for the foreseeable future. SAMHSA SOGI Center of Excellence is a fantastic resource for folks looking to get information on how to do behavioral health care with LGBTQ youth and adults alike. Their compendium of webinars and trainings is unrivaled. It's fantastic, and they're free of charge. FDA had a former campaign called This Free Life. It's fairly outdated now, but it's got some great resources if you want to diversify, and has shown to have some efficacy. The Truth Initiative has been mentioned multiple times. They too have great resources specific to LGBTQ communities, among many others. And then, of course, please visit our website to be able to access these materials. When our toolkit goes live, it'll be available there. And it's a great way for you to be able to connect with us so that we can go out and meet with you, answer questions, and be able to provide this training once it's available. And with that, I'll say thank you very much.
Hello, everyone. My name is Maggie Clemens. Sadly, no, I'm not a doctor, although really wish I was. And I am the state client manager for RVO Health, which is the vendor for tobacco cessation services in the state of Maryland, aka Quitline. So I did want to take a brief moment to thank David Quinn and the team at the Center for Tobacco Prevention and Control for your continued partnership directly with the Quitline. Absolute pleasure to be working with you all, and I'm very honored to be here, as well as the TCRC team for inviting me to speak and giving me this opportunity to be present and be with you all today. I'm newer to the tobacco prevention community, and I have already learned so much today, so it's really, really such an honor to be here. I am very excited to speak with you all today about how we have integrated SMS texting specifically into the Quitline experience and how we've utilized it to better support people along their quit journey. So for some of you today, this may be the first time you're hearing of what the Quitline is. So I did want to take a quick moment to kind of explain it at that surface level. So it really is integrated telephone, text, chat, and web-based services that support the state participants who are wanting to quit commercial nicotine and tobacco use. We utilize evidence-based treatment that includes coaching services, web-based support, as well as free nicotine replacement therapy to certain populations, like we were discussing earlier. As well as a number of tailored content to specific populations that really help to focus in on different barriers that come across for those populations in their quit journey. So ultimately, we really are trying to help create a customized quit plan, and we're constantly trying to utilize engagement with local, regional, state, and national meetings, conferences such as this one, as well as just a number of partners partnering with different external groups to increase our offerings, especially with those state teams that we work with, and continuously improve the member experience and really create that quit path that is customized to each individual. We also provide a number of different trainings and outreach efforts that really get as many people as engaged with the Quitline as we possibly can. And we're constantly looking for ways to improve those outreach efforts and trainings and get more people involved in the Quitline. So I did want to do a quick overview of kind of the state of Maryland in particular. And so would like to do a year in review of kind of the Maryland Quitline numbers from 2024. So for total enrollments, we did see that there were 6,348 enrollments with the state of Maryland, which is truly, truly great in comparison to a number of our other states. So bravo to our Quitline team engagement. And within that group, we do see a number of different specialty populations and groups that we kind of are honed in on, as well as that Live Vape Free platform that I will be discussing in a little bit as well. But within that group, or that 6,348 individuals, we saw there were 1,973 behavioral health enrollments, 4,276 standard enrollments, 90 pregnancy and postpartum enrollments, and 9 youth digital only enrollments. So definitely that youth digital group is one that a little trickier to get the 13 to 17-year-old population involved directly in the Quitline rather than some of our other vaping offerings, but it is a group that we will be hoping to hone in on as we move forward with progressing our programs. On a separate note, that Live Vape Free, like I said, is a separate entity that really focuses on young adult and youth vaping individuals. And we did see 92 enrollments for 2024 within that group, which we're continuously, again, trying to improve upon and spread that awareness there. So do we know we have a number of providers in the room tonight or today too? So I did want to briefly talk about referrals and how important provider or community organization referrals are to the Quitline. So we do see that there are 4 different types of referral methods, but there are 3 different types that are utilized in the state of Maryland. That's that EHR connection, which is directly connected to your electronic health record within the health system databases. We also utilize fax referral methods as well as an online referral portal. So we do see that the vast majority of our healthcare systems are utilizing that EHR methodology, but we do see 7% utilizing fax forms and 2% utilizing that online referral portal as well. So one thing that we are trying to improve upon is the acceptance rate that we are seeing with these provider referrals. So that really is that time where providers and outreach members can kind of educate their participants that they are working with to kind of give them an idea of what the quit line is or that Live Vape Free program is. And we are trying to then connect them directly to the quit line through that referral method. So nationally, we are seeing that 21.7 acceptance rate is pretty in line with what we're seeing in other states. But that's something we are trying to improve upon because we would love to see those referrals really becoming a higher acceptance rate and getting people actively engaged in the quit line rather than just pass along through that referral and not wanting to engage. Oops. So now that we've gone over kind of the quit line as a whole, I do want to shift gears and hone back into the quit line's texting capabilities. So as technology progresses, the ability to meet someone wherever they are through texting services has become like more and more vital to keeping people engaged in programs like the quit line. So we at RVO Health have like really tried to create a number of different methodologies through SMS texting that really do just that and try to keep that ongoing engagement and really just meet people where they are. So text messaging services are integrated throughout the entire quit journey, from initial enrollment to ongoing interactive messaging, as well as re-engagement and program evaluation efforts. And when we kind of break it out, there are 5 different types I'll be speaking about in particular today, but we can also kind of subcategorize them into three boxes. So that first box that I'll be talking about is more of that programmatic content, and that is inclusive of the text to start and marketing text capabilities. By programmatic content, I mean more automated messages that are not personalized to the individual and they're not interactive in any sense, but they are that kind of baseline outreach attempt to engage with that participant in some way. Then the second bucket would be that referral SMS system that you're talking about, how it is related to provider use and the way our community outreach members can really help people integrate with the quit line. So I'll dive into that in a little bit as well, but very excited to talk about what we've integrated there to try to increase that referral acceptance rate, as well as increase awareness of the quit line and what our plans are for moving forward. And then finally, that last bucket is more of a interactive content capability. And that includes our Quit for Life SMS, as well as our text to coach capabilities. So now I can dive into all of those more explicitly. So that first content that we were talking about, text to start, you may have heard it called text to enroll previously, and we have kind of re-envisioned it to be text to start. And ultimately, this allows any quit line participant to enroll in the quit line via a text message. So rather than having to call the quit line directly and get those extra resources, at any point, they could text READY to 34191 or LISTO for our Spanish-speaking members, and they would be able to go through the online enrollment into the quit line. So don't have statistics there quite yet, but we are seeing that people are starting to engage in that methodology, and it's something we do want to really put out there again as an opportunity for folks to get engaged in the quit line in that sense. Additionally, we do also have our marketing texts. So this is something that when they are going through the enrollment, the participant would actually consent to on their preference page. And it really allows for automated program outreach that allows for iterated content to be sent to our participant. So that's like, welcome to the quit line. We're so excited to have you. Remember, you have a session coming up. Or after they complete that session, they would receive a text saying, thank you for being involved with your coaching session. We're looking forward to having you to the next one. So again, all messages that are very important to kind of keep those things on your schedule and in that front of your mind, but they're not personalized or interactive in the sense where you would need to respond and interact in that sense. So some of the statistics we have involving specifically those marketing texts, we did send 1,025 total texts to Maryland participants last year. We averaged 2.48 texts per participant who opted in. So again, there's kind of that very hard balance of you don't want to send somebody too many messages and kind of overflow their inbox. Because I know nobody likes being spammed by all these kind of automated messages, but utilizing very intentional points, such as these session reminders or a reminder to fill out their nicotine replacement therapy survey, really, we do see an effectiveness there of getting people re-engaged in the program in those different functionalities. So on that point as well, we did see that 38% of the opt-in users utilized that text that they received to go back and complete that nicotine replacement therapy survey that they may not have completed during their initial enrollment. So that's giving them that access to that nicotine replacement therapy and really, again, helping to support their quit journey. As for a referral SMS, this is where on the actual referral form, the providers or outreach members can talk to the participant about whether they would like to consent to text messages directly on that form. So kind of preempting that initial enrollment section. And so as we're innovating, we really are utilizing this ability to text a referral prior to our initial coaching outreach to increase connection and conversion rates. Because again, they're receiving that reminder that, hey, you're going to be receiving a call from the quit line, or like, we're so excited to get you enrolled in the quit line. You'll be receiving a outreach attempt from a coach in the next X amount of hours. So it's kind of, again, bringing that to the front of their mind of, oh yeah, I did say I was interested in looking into these services. I'm excited to hear from this coach. Especially we do run into some issues where depending on the telephone provider, the number does not pop up as the quit line calling, and it does come up as that 1-800-QUIT-NOW number that they might not recognize. So I don't know about you guys. I never answer when a spam person is calling me. So on that note, this helps to kind of, again, remind those people, hey, so a call is coming in. Maybe I should be answering those spam calls today. And it's not a spam, it's your quit coach. So it's great. Looking ahead, so right now we do only have that capability on our web online referral portal and fax forms, because it was very easy to integrate that option on those methodologies. And that was actually done in Q3 of last year. But we are really hoping to add that to the EHR and HL7 systems within hopefully the next year, closer to 2026. So we'll keep you all updated on that, because I know that is that larger group that is utilizing those EHR system referrals. But again, we really are looking in on honing in on that consent to text conversion rate and getting those referrals accepted rather than just ignoring those interactions from coaches. So when comparing to Maryland to kind of the national numbers, we do see that there were 264 total fax and online referrals in 2024, and 41 of those fax and online referrals did opt in for receiving text messages. Of that 41, 14 did accept, which is 34%. Again, that's of only beginning this initiative in Q3 at the end of the year. So we would love to see those numbers continue to go up, and likely they will with how it's trending across other states. On a national level, we did see that 29% of online fax referrals and the online referral portal were consenting to SMS text. And within those groups, we saw upwards of 20% increase in conversion rates. So that would be improving that 21.7% of accepted referrals in Maryland all the way up to 40 and hopefully moving towards 50. So again, love to see those outreach efforts really improve. And this, I just wanted to give a brief showing of if you are one of the individuals who would be making that referral, this is where you could find that may we send text messages to this number on both the fax form on the left and on the online referral portal on the right. Now, jumping into kind of more our interactive texting capabilities. So again, something that they can consent to on their preference page and during enrollment would be this Quit for Life SMS, and it is also linked to Text to Coach. So Quit for Life SMS is one of those more personalized texting experiences where a text is sent, but it allows for a more dynamic content experience that adjusts based off of how the individual participant responds. So maybe they would ask, hey, you had your first coaching session. Are you looking forward to hitting your quit date? And they would respond yes or no. Then after that, they might do something or ask something that's a little bit more, how are your levels of stress? And if based off of 1 to 10, something like that. And based off of that response, it would take them, I talk with my hands, I apologize. It would take them on that different route and different journey. So again, really trying to make that more of a conversational interaction. And it's all not required, but it's just something that, again, is kind of reminding them of their quit experience and reminding them to continue to engage with the program. So with 2024, we did see that 3,222 people opted in for this text-to-coach capability. 71% of users responded to 1+ text message. So again, showing really good engagement there on just levels of interaction with Quitline outreach. And then 33% of users used at least 1 keyword. So once it got more into the nitty gritty, really talking through that experience, a little bit of fall off, but still, again, that good initial interactivity. And looking forward, something we're looking into is kind of integrating AI into these capabilities, as well as other unique personalized methods. And so looking forward to sharing where we come on that front as we move forward, but nothing quite there yet. Just keep your eyes and ears open. And then finally, the last capability that we'll talk about before we jump into Live Vape Free is our text-to-coach capability. So again, they would need to kind of consent to that text-to-coach on the preference page and would then be engaged with that Quit for Life SMS. But at any point, no matter if they received one of those text messages or not, they can text coach to their that number and would be able to immediately get connected to a coach, either for a one-off experience or one-off question or conversation. Maybe they're kind of walking around and realizing they're getting a sudden urge and they want to talk to somebody. They could immediately start texting a coach to kind of help them through in that moment. Additionally, if they had a number of questions or wanted to engage in a full coaching session, they can. And so that's something that we're really trying to promote, especially, again, really honing in on this ability to meet people wherever they are. Like when you're trying to quit, these things come up when you kind of least expect it, and you want to be able to connect them directly to someone who can help you through that experience wherever you are, and not be limited to, oh, I have to call in. And especially too, in our younger users, we do see there is kind of that phobia or deterrence from actually engaging in online or telephonic phone conversations and completing those coaching calls over the phone. So by providing this texting capability, we're trying to kind of gear more towards that younger generation that may be a little bit more prone to completing these engagement methods via text. So hoping to, again, expand our capabilities there. Specifically within, again, the statistics for 2024, we saw 3,222 text coach opt-ins, and then 43 completed coaching sessions via text. So again, more so, I think a lot of people are not aware of this capability, and we're trying to spread that awareness that, hey, texting the coaches directly is always an option. So excited to kind of expand outreach efforts there. And then finally, I know it was briefly mentioned earlier, but we do also have a vaping program that we are very, very proud of and have really been honing in on for the last couple of years. And it is called Live Vape Free. And so really it is actually a completely texting-based program for youth and young adult vapers that teaches them how to quit vaping for good. So ultimately, participants navigate through 9 different lessons, all accessed via a linked text message. And it gives them also access to online content such as videos, quizzes. I know earlier we were talking about TikTok. All of these videos and things are very catered to the younger generation's perception of social media and do have a very TikTok-esque vibe. So we're trying to really hone in on what works well for these individuals, but also includes podcasts. I know a big podcast generation as well. Flip cards, and then also provides 24/7 chat with the coach, where they could actually do like an online chat on the dashboard, or can also text via texting. So this is a little bit of a shift of the year to date because this began on 2/5 of 2024. But we did have 80 enrollments in the Live Vape Free young adult group, which is the 18 to 26-year-olds. That's very consistent with average numbers. We do see a higher percentage of that young adult age group interacting with the vaping programs, and are continuing to kind of increase outreach efforts there as well and target that population. And 65% of those individuals opted into additional texting services. 71% of those then responded to 1+ text message. And then we did see that drop off of clicking the links within a text. And I think that does go for kind of that fear of getting your personal information stolen. I know I get a little wary of links and things like that. So we're hoping to kind of educate that, these links are safe to bring you to the content that we are trying to target on the Live Vape Free website. Additionally, the Live Vape Free youth, we did see 12 enrollments from age 13 to 17. 60% of those individuals opted into additional texting services. So actually a little bit of a bump of folks who were willing to kind of participate with the texting, but did see a 50% responding to the 1+ text message. So again, a little bit of a dip in actually those who are interacting with those texts, but an increase in the number of individuals who were utilizing at least one link within those texts. So that is it on my end. I know I went through a lot there, and again, just wanted to say how thankful I am for my continued partnership with the Quitline and every single member of the community who is here to support these numbers. But happy to jump into the question section next. So thank you.
So thank you to all the wonderful speakers. I'm going to invite all the speakers up here, and we are now open for questions. So I put 3 chairs over there. I think you all will be good on this side so you can be seen. Okay, and Austin has a mic. Any comments, anything? Well, I'll kickstart this then. So one of my pet peeves is, you don't know this, Maggie, but I've been complaining for years that when the Quitline calls you, it should say 1-800-QUITLINE. Or when they text you, it should say Quitline. And it never does. And one of the things I'm thinking in today's world, should you always text before you call? Instead of making a cold call, should we always text with Quitline in the text or somewhere? Because nowadays when those texts come with the numbers, I don't even open it half the time because I don't know what they are. But if it says Quitline someplace, I might say, okay, well, what's this? Oh, they're going to call me today. Maybe I should pick up the phone. So what do you think of that? We need a mic up here. Do you want to step up? Sure.
Yes, I know specifically, especially in regards to the telephonic services, that's a big barrier that we do come into, like I was referencing. There are certain carriers that do allow it to populate as either 1-800-QUIT now, rather than the actual numbers that spell out Quit Now, or like Quitline is calling. And unfortunately, for some reason, there's just a couple of telephone carriers that they cannot integrate that capability. So it's definitely something we're continuing to try to push against. But that's a great position on actually changing the numbers that populate when you receive the text as well. I know within the content of the text, they will call out that it is the Quitline that's reaching out. But I agree that the number that it comes from does not. It normally is that kind of jumble of random numbers that you're not sure why they populated. So definitely something that I can bring back to my team and see if there is a way to kind of have that populate as something else.
Well, we have one. The woman in the gray, she was.
Oh, I'm
By Austin. Nice, Austin.
Yeah, you can tell
Her first.
Sorry. Hi, my name is Chris Bloom. I'm with the Anne Arundel County Department of Health. Thank you to all the presenters for the great information. This question yeah, it's a question, I guess, is for Dr. Moran. As a lifelong fan and consumer of television and film, I don't know if your team has any information or done any research on this, but I've been around long enough to remember when smoking was very prevalent in that media, and then it kind of went away. And now I'm noticing, and it triggers me, that it's come back into television and film. So I don't know if you can comment on that at all.
Yeah, it definitely has, especially with the advent of all of the many streaming services that we see. There was a report, I think it was Truth Initiative, that did this, where they actually analyzed the presence of smoking and tobacco related content on popular television, like streamed television shows with young people. And they just found like an exorbitant amount of tobacco. Netflix actually did take notice, and I think started to decrease the amount of, like smoking on screen, but it's really insidious, and in many ways is almost more attractive to young people, because at least with advertising, there's often a very explicit, persuasive intent, which young people tend to find a bit objectionable, right? They don't want to feel like they're being, sold something. So I think it's very concerning. I would love to see all tobacco products erased from any mediated image, for the rest of our lives. But I think you get pushback from the film industry and the television industry sometimes, because they often view they view like a cigarette or a vape as a signal about a character, right? And it's their artistic discretion to use that, and they don't have time to go into exposition that this person is, that has these types of characteristics. They just convey it with, a cigarette. And obviously with First Amendment rights, it becomes like very challenging. But yeah, I think that's an area that we as a community really need to push more towards, for shows, especially that are popular with youth.
Would you mind using the microphone, because we have, sorry, 105 people online.
I'm sorry. If like film and TV is being sponsored by big tobacco and vaping companies.
I do not think so. But I am not positive. So I will, that's something I think that's worth looking into. But my understanding is that no, that it's simply the filmmakers themselves most commonly. Yeah.
Hi, Carrie Ann from the Dorchester County Health Department. So I was thinking of the same things, sort of like, how is it okay that we're advertising nicotine on social media and other platforms? Why doesn't that just fall under the tobacco nicotine rules? So I wrote some things down so I didn't take too long. Where is it? Okay, so in 1998, billboards, sporting events, concerts, they could not promote or have nicotine tobacco stuff at their events. But I saw this the slide that Austin had up that had the Jewel people in front of the Jewel. It's like, and so that's a film festival. So why is that happening? And also, I know you don't have an answer to this, but it's like weird. And also, influencers, like Truth just put this article out in the beginning, the end of 2024, about how they found out that influencers that were promoting vape products to youth were actually being paid by the tobacco companies, which is illegal. They have strict regulations for that to happen on social media, but they're not being held accountable for it.
Yeah. And it's so like a lot of this, I think, is the fact that the industry is evolving so quickly that the laws we have in place are really struggling to keep up, coupled with the fact that the industry will just come after like any regulation, right? With just lawsuit after law, like think about like graphic warning labels, right? And like what we've been going through to try and finally get those on packs. And so, like I think with a lot of the restrictions on cigarette advertising, right? It's not necessarily the same as e-cigarettes, right? Like if you flip on, not as much lately, but as recently as a couple of years ago, I was seeing just ad after ad for e-cigarettes on network television. And so it's just incredibly complicated. The industry is always going to kind of like push the the punishments for violating those are just not sufficient to stop them from doing it, especially when they think they can sneak in under the radar. And it like the amount of work, for example, in that Truth Initiative report that went into like untangling those relationships is like the amounts of effort involved is just massive. And so, thank goodness we have folks like that doing that, but it's a lot of work. And the industry knows that. And they also know that they have a lot more money and a lot more people. And so it's just, it feels like fighting an uphill battle. But the more we advocate, I think, for stricter enforcement and stricter regulations to begin with, the better off we're going to be as a tobacco control community.
And thank you. And I also have a question for the quit line lady.
Yeah, just hold on just a second. So I'm going to ask Jessica to just speak to us for a second about the free giveaways and trucks and such at Pride events.
Yeah.
Yeah, I think that would be interesting too. The other thing I wanted to mention is that Fellow is partnering with Red Bull to be at the Formula One kickoff in June. So there are these strange partnerships too, but could you speak to Pride events for a second?
Yeah. So I will say, personally, I haven't seen a giveaway in a minute, but they likely probably still happen. But the sponsorships are key. I do a lot of alcohol related work too, and alcohol sponsorships are very prominent at Pride events. They'll oftentimes even sponsor whole parades and booths that tend to attract a lot of interest, including at, like Silver Spring Pride is one. They had an alcohol sponsorship booth last year, I believe. So it's just kind of built into the Pride culture. And bars in particular have very curated advertisements within them that are specifically for LGBTQ communities, both for alcohol and tobacco.
Thank you. So over there.
Can I just ask one more question?
Would you mind just stating your name if you don't mind?
Sure. My name is Carla Wilson Batty, and I'm from the Center of Addiction Medicine at the University of Maryland. My question is, we talk a lot about the vaping and cigarettes and youth, but I haven't heard anything about the use of cigars. And that's kind of a personal thing with me because my boyfriend, he smokes cigars and he always says, well, I don't inhale, so it's not as bad as cigarettes. So, we always talking about like the products of nicotine, and I just was curious why we never talk about cigars. I'm sorry, was that off topic?
Any of you want to address this or should we take this offline? Because cigars, as I was going to tell you, is that it's the manly thing to do, right? And that's how they're advertising it, isn't it? Yeah. So anyone?
I can speak to
Yeah, of course. And little cigars.
Yeah. So I can speak to this on two different levels, but I also don't want to oversell my expertise on this either. So among LGBTQ populations, cigars are often the least likely endorsed tobacco product used, particularly, I think, for young people. The accessibility and potentially allure of things like e-cigarettes and combustible tobacco, we tend to see those numbers. The prevalence of that use is much higher in that community. However, we do know there are other demographic differences in the use of, for example, cigars, little cigars, cigarillos, and things like that, which do impact the communities that we look at. But I don't know of any research that really tackles that in these the intersections of those communities specifically. Yeah. So an unsavory answer, but that's all I've got.
Yeah, so that is a very good question because when we look at West Baltimore communities, we see little cigars. That's what we see. and Black and Miles, really, to be specific. So we really need to be studying it a little bit more. So that's a challenge for everybody in the room. And I guess we'll follow it with any other questions. Anybody?
I have a question.
Yes.
Sorry, just a quick question for the quit line. How do you track your actual quit rates? Do you have like any follow-up?
Yes, so quit rates are determined, well, it also depends on the state. I do believe the state of Maryland uses us for their evaluation services. But our typical, the way we do our follow-up is that we actually follow up with the individuals 7 months after their quit program has finished, or after they became an inactive user of the program. And we utilize the surveys that we then deploy through that methodology, which if we consent or if they consent to text, that actually allows us to engage with them to reach out and say, hey, you were part of the quit line and we would love to kind of see how you are doing. Would you be willing to complete this follow-up survey? And if they say yes and join in the call, then we actually get higher numbers that way. But yes, that 7-month follow-up, it, I think, measures their intent to quit, as well as the number of days since they last smoked, as well as a number of different other factors. And the complexity of that evaluation depends on kind of what the state asks for. But we do provide all those services, and it's usually monitored directly through the quit line. Yes. Yes, which I don't have that on hand. Potentially we could get that for you in the break, but yes, we do have that. And I believe this next evaluation, I think the last evaluation results were from the 2023 evaluation, and the 2024 evaluation would be coming out shortly. So yeah, no problem.
I thought there was a question right here.
Oh, we need to go to break.
Oh, you need a mic. I need to go to break.
Yeah, we get the next session starts soon. You want to give people a break?
Okay, well, one last question.
Sorry for holding everyone up. So my name is Natalie Hall. I'm from the Howard County Health Department. My question is for Maggie, and it's regards to kind of more of the business piece of the quit line. Your CR, and if this isn't your role, that's fine. Just tell me. The CRM, so the customer relationship management system that the quit line uses. Do you know if that's integrated with social media?
Yes. So it is integrated with the marketing and social media campaigns that we help states run, which we are actually currently doing a marketing campaign with the state of Maryland. So that is integrated there. So we have all of the click to conversion rates and all of those numbers. We're able to basically watch the social media campaigns metrics from initial click all the way through the entire enrollment, and are able to kind of give those results to the quit line directly. Otherwise, though, if it's a marketing campaign or initiative that we're not directly linked to, then we can't see those types of interaction capabilities. But we are able to kind of monitor the numbers of enrollments, monitor population changes based off of kind of the years of engagements and enrollments in those specific populations that campaign may be targeting. So our capabilities are wide, but are limited based off of kind of what the campaign is doing. And it's definitely something we're trying to expand upon our abilities as well, and utilize with our partners to engage in those campaigns through us so we can see that throughout the entire experience.
Okay, I was just thinking about if someone is typing in, so like a keyword, right?
Mhm.
So if someone's on a platform and they type in vaping or a specific, would that then trigger a quit line
Yes.
advertisement?
Yes, I would have to get the information for you on that more specifically, and I don't have a ton of transparency to that, but I do know we help bolster the targeted campaigns on Google. I think I know what you're talking about of, yeah, if you're searching, we push them to pop up as the number one rather than sometimes other advertisements and things like that populate, right, and not the services that we'd be hoping to promote. Yeah, no problem.
All right. Thank you to all our panel speakers. Thank you so much. You're okay to go? So, all right, so we're gonna move into, you all can sit down. Thank you. So we are going to move to our next session, which is a little update, the state of nicotine and tobacco. So this time we were trying a new title and we actually got CME for this. So the state of nicotine and tobacco in Maryland, which will be presented by Dana Moncrief. Dana Moncrief is the director of the Maryland Department of Health Center for Tobacco Prevention and Control. She's been in the state service and with the center for 18 years. As part of her role, she oversees the statewide tobacco control program, focusing on public health efforts to reduce youth tobacco use and help those who use tobacco to quit, reduce exposure to secondhand smoke and vape, and support local efforts. And more recently, Ms. Moncrief has established a new branch at the center to implement programs addressing the public health impacts of adult use cannabis with a focus on youth prevention, treatment training for healthcare professionals, and consumer safety. Ms. Moncrief holds a Master's of Health Science from Johns Hopkins Bloomberg School of Public Health, a Bachelor of Science degree in biology from the Penn State University, and is a certified health education specialist. Welcome, Dana.
Hey, well, thank you so much for that nice introduction. I'm right before lunch. If my stomach growls, please give me some grace and pretend you don't hear it. So thanks again for coming today. This is a great location and hope everyone was able to find parking. So I'm going to go ahead and start. We're just going to do an overview of what's been going on at the state level and some resources available for you all, our partners, local health departments. So my center is actually part of the Prevention and Health Promotion Administration within the Maryland Department of Health. We just came up with a new mission and vision. So here we are. This is probably one of the first presentations to show off the new mission vision. So the PHPA is, the mission of PHPA is to protect, promote, and improve the health and well-being of all Marylanders. And the vision, PHPA envisions a future in which all Marylanders have equitable opportunities to live, thrive, and be healthy. Here's our agenda. I will move quickly through this. I think some of the things we've already talked about from our great speakers and presentations. So talking about the Center for Tobacco Prevention and Control. So our office is based off of the CDC best practices. And you'll see the 4 bullets here to prevent youth and young adult from ever using tobacco, provide resources to assist residents who are ready to quit, eliminate exposure to harmful toxins found in secondhand smoke, and identify and eliminate health disparities among population groups disproportionately affected by tobacco-related disease. I'm going to start at the cannabis branch. This is also based on CDC cannabis work, and it has several pillars. You'll see monitoring trends, advancing research, building state and local capacity, supporting providers and health systems, and improving knowledge and awareness. These are all things that we're doing in public health already. So certainly we can apply that to our cannabis public health initiative. And there are several components within tobacco control that also apply. There are definite overlaps for addressing cannabis use prevention. We work with several partners, local health departments, of course, Legal Resource Center, TCRC here today, several health systems, the Quit Line, and the list goes on. So we're certainly happy to work with everybody. So on the horizon, we at our Center for Tobacco Prevention Control are in the process of updating our name, mission statement, and vision. Why? Because Center for Tobacco Control does not reflect the Cannabis Public Health Branch. So we are updating it to make sure it's reflective of all the programs that we're working on. Many states are actually migrating from the word control, just with a negative connotation to that word. We have nicotine and tobacco. Do we use both, one or the other? Many are using nicotine to cover all products, all tobacco products. And then, as I mentioned, PHPA just recently updated the own mission and vision. I'm not going to talk a lot about the tobacco quit line. Maggie did a great job providing an overview, but there are several ways, free 24/7, available to 13 years and older, assisting in any tobacco product, tobacco or vape. There's free NRT that we're able to provide, patch gum, lozenge, and or combination therapy. And then we do have specialized programs for those with behavioral health conditions, pregnant persons, Medicaid. We have the new menthol program. And then as Maggie talked about, vaping and youth populations. So you can go to smokingstopshere.com to get more information. You'll see on the right side here, this was actually based on the evaluation. I think someone asked about evaluation and quit rates. So our statewide quit rate is actually 37%, which is actually higher than the national average, I believe is 30%. So callers are 5 to 9 times more likely to quit using the quit line versus trying to quit on their own. So we have a 97% satisfaction rate, and 95% of web enrollees stopped using tobacco for more than 24 hours or more. Again, Maggie did a great overview of this. I will skip this part. So we also have a menthol support track. As I mentioned, this is new. Actually, it's been a year this month. Participants are enrolled if they self-reported that they use menthol products. So they're in this program. Over 3,500 participants were enrolled in the support track. And you'll see demographics here, 62% were African-American and Black, and 32 white, and then 6% other. Looking at our health systems approaches, we are currently working with Johns Hopkins, Mosaic, University of Maryland Nicotine Health Center, University of Maryland School of Medicine, Johns Hopkins, and Gaudensia. So working with these partners, they are using the CDC tobacco change packet, working to implement tobacco use dependence, doing trainings, referring to lung cancer screening, referring to the quit line. So you'll see on the right side, all the great metrics that we have. They're also training partners and professionals and clinicians on the clinical decision toolkit or tool and the EPIC tool. So a lot of different trainings going on, and this was all in FY24. Increasing referrals to the tobacco treatment and lung cancer screening, working with Johns Hopkins. The purpose of this contract is to increase referrals to tobacco treatment interventions, as well as increase lung cancer screenings for high-risk adults. And really, again, integrating evidence-based strategies into clinical care policies, protocols, and systems. And you'll see here, there's over 500 healthcare professionals trained, including as well as over 250 community leaders and licensed community health workers. These trainees actually went and provided 172 lung cancer screening referrals. So it's great to see putting this into practice. I'm not going to talk about TCRC. We have, this is, I'm sure you've heard a lot today, but I do want to give a round of applause. I know we're not done yet, but this has been great so far. So thank you, Dr. Khanna and your team. This is, it's always wonderful to work with you. Definitely a great resource center, so encourage you to visit and reach out. And I'm not going to talk about this because Dr. Fish did a great presentation as well. Please go visit this website. A lot of great materials. It's just done a really nice job on this program. We have a youth engagement program with tobacco control. We're funding CADCO. So we have recruited 6 youth to participate in a core youth advisory council. There's several meetings, 2 hybrid photo voice activities, some other trainings here. We actually did hold 3 trainings for adult advisors. So this is a youth-led, adult-supported initiative. So working with adult advisors, certainly to help them implement communities and youth groups and best practices. And save the date, we have our annual youth summit. It's being planned for Saturday, June 14th. Some more information will be coming around, and you'll see some information in the middle of the table, I think, with the QR code here. We are working with tobacco-free campuses. So Sarah Dimitro's sitting back there. She's done a great job of reaching out to 57 Maryland colleges. We've met with 14. You'll see a list there of the presentations and future outreach events. Certainly, if you are working with colleges and you want to partner, please reach out to Sarah. We certainly want to build up our presence on college campuses as well in tobacco-free and nicotine programs. We fund the Legal Resource Center for Public Health Policy Tobacco. And Brooke, I saw is here somewhere. So certainly go visit her, say hi. But the Legal Resource Center has been our partner, I believe, since 2002. So they are there to provide technical assistance to our partners and residents as well. Many different tobacco policies. They have many educational webinars and trainings in person, material that they can provide, you can download, or they have them on hand, I believe. And then they also track legislation. They're very busy right now. It's nearing the end of legislative session, but they do host bi-weekly calls and go over every public health related bill and the status of it. So it's very informative and we appreciate them doing that. Also save the date. Their 9th annual conference will be June 4th and more information to come. Oops, I don't know what happened here. Several of our mass reach tobacco prevention communication efforts. We do have a statewide media contractor who is helping us for actually rebranding some of our programs, moving away from Smoking Stops Here and looking at other options for rebranding. So we have our Continue the Good, which is working with behavioral health populations, the vape experiment, trying to overcome the myths of using vapes, targeting youth and young adults. Quit Smoking for Good. So I believe it's the one that Maggie referred to that we're working with the Quitline provider, putting out some other ads. 21 or None. This is, of course, related to retailer. Hoping or encouraging retailers not to sell to those under 21 and to follow the law. You'll see on the right side, we actually worked with our media vendor to do some support for Pride events. And one of their subcontractors is iHeartMedia. So they were able to go out to these events and provide education and engagement. The more unique opportunities, so you'll see on the left, and I think we're doing it again this year. So it's for World No Tobacco Day. It's actually a digital video and they're on the big screens. I don't know if you've been in Baltimore City lately. They're on the side of parking garages or buildings and they're huge. And it's really neat to see this big world on the digital screens with information about the Quitline too. We work with WIC, so they put out a cookbook every year. So we added this ad, Make This a Quit That Sticks. Information about the pregnancy program we have with the Quitline. And we did have a unique opportunity with, the words are gone, with one of the veterans networks. And so they really like their vape experiment ads. And so they were able to co-brand it. And you'll see they have even information about the military-based smoking cessation program. Looking at local programs, we have our cigarette restitution fund programs. I've seen many of the local health departments here, so happy to see you. Thanks for making the trip here. An overview, they establish community outreach and education on tobacco prevention, establish partnerships with schools, and encourage and support tobacco cessation, as well as they do many of their enforcement programs for tobacco retailers. Each jurisdiction maintains a community health coalition that represents the diversity of that jurisdiction and utilize these coalitions to help develop tobacco plans. Other local programs that we're supporting are the Diabetes and Chronic Disease Program. We say TDC to shorten it. So this is addressing tobacco prevention and long-term effects of tobacco use through community partnerships, reducing risk factors for type 2 diabetes through lifestyle change programs, and certainly looking at this through a health equity lens. We supported 4 local health departments on an oral health program. So they are funding programs and dental hygienists to conduct oral health screening. And then we have the patch program. There's a handful of local health departments funded to address tobacco use prevention or cessation for pregnant persons. So fiscal year accomplishments, You can see from the local health departments, several diverse partnerships were forged. Many students, over 58,000 students, and teachers and staff were educated. There's over 93,000 individuals were educated at local programs. Certainly supported tobacco cessation, not just referring to the quit line, but their own cessation programs. And as I mentioned, we have the oral health program. So over 4,600 community members were screened for oral tobacco or oral cancer. So moving to our enforcement efforts, we have our no tobacco sales to minors, 21 or none initiative. So we at the state level have the SINAR program and the FDA program where we have commissioned officers through the FDA. We also have our local health department programs that I just mentioned. For our SINAR program, we will be resuming inspections here in April. And then we also have our outreach material. So 21 or none media placements, radio ads at point of sale in retail locations, LinkedIn, transit. We just sent, or we're planning to send more toolkits to over 6,000 retailers. And that's sharing information about updated laws and signage and how to do ID checks. And anything's downloadable at notobaccosalestominors.com. And this is, referring to retailers here, that we have signage that's actually compliant with the parameters within the law. So easy just to order that, print it, and they can order and we can ship it too. And the Alcohol, Tobacco, Cannabis Commission did just put out a one-pager, and that's for retailers about following the new Tobacco Retailer Modernization Act. I put the link here. We could put the actual link when we send these out, but it's a nice one-pager, easy to follow, just for retailers and making sure they comply with the new law. We just started a partnership with Community Builders, and they have a network of faith-based partners in Prince George's to address menthol. So this is a great new program. Kelsey is overseeing this, and we'll get this off the ground. I know many of the local health departments are also doing some faith-based initiatives, so this is certainly to help support the overall program. And begin in October, and it is actually youth-centered and works to build leadership skills in tobacco literacy. You can see here at the bottom, the very shocking, maybe not shocking, but disparity rate between African-American and white adults who use menthol. So it's a 77.3% disparity rate. So this is definitely an important initiative, and certainly something we can partner with others across the state. Moving to data, we do work with the BRFIS, the Behavioral Risk Factor Surveillance System. It's an annual survey. Roughly 15,000 residents are surveyed every year. The most recent data available is 2023, with the 24 data expected this fall. So some data from the 2023, you'll see, and this is great, it's been going up. Almost 71% of Maryland adults are never smokers. 20.3% of Maryland adults are former smokers, and 9.1% of Maryland adults are current smokers. And you can see with the current smokers in 2011, we were at 19.1, and now we're down to 9.1, which is a great accomplishment and going in the right direction. My office also oversees the Youth Risk Behavior Survey, and we combine that with the Youth Tobacco Survey. This is mandated by state statute. We just completed the 24-25 survey administration. So that data should be available next spring. But this is an incredible feat. So we have almost 70,000 students that were surveyed. 369 schools were visited. This is both middle school and high school and the public school. And we did have new modules in place this year. Additional cannabis questions, access to mental health services, and STI, STD testing for high school only. So those results will come in. We do work with the CDC on this, so we're hopeful this is going to continue. But we should have the new data publicly available by the spring of next year. And because we do have such a large sample size, we are able to get jurisdictional level data for most of the measures, which is nice. I think we're one of the few states that is able to do that. just looking at some data. So the overall e-cigarette use rate was 14.3%. Not much difference from the previous surveys, which was 14.7, I believe. But when we break down the data a little bit more, you can see that there is a gap in e-cigarette use among female and male high school students, and it's been widening. And you'll see an increase in the use among female high school students. Something to keep an eye on. And then looking at the decrease in cigarette use for high school, and this is from 2014 to 2022, it's 8.7, we're down to 3.2%. In high school, and a decrease of 50% in middle school. So we're down to 1.2% of middle schools whose students who say they use cigarettes. Someone had asked about cigar use. We did actually see a significant increase in cigar use among high school youth. I believe it's 4.5%, up from 3.1, 3.2. So this is something to keep an eye on. And I know, there's a question over here about that too. So looking at the disparities with the 2023 Burfus and 22-23 school year YRBS, we did pull out some disparities, particularly looking at the marijuana or cannabis use. Looking at youth tobacco users, they have a 27 times the odds of using marijuana and then those not using tobacco, and it's even 3 times for adults. And also looking as well, for youth, there's 3 times the odds of feeling persistently sad or hopeless, and adults 2 times the odds of being diagnosed with a depressive disorder. So definitely some things that we need to consider when we're pulling our programs together. We just completed a new program, something very nuanced. So we did an ethnography study of the Maryland veteran tobacco use product culture. We worked with Abredo Analytics, which is a veteran-owned company, and they have done focus groups and data collection with 125 veterans that participated in this survey. Our formal study report will be expected to be released this summer, but definitely something unique and different that we've been able to do, and hope to apply this to other populations moving forward. And of course, we have Cannabis Public Health for expanding the infrastructure. So I'm happy to say we have a new program manager to help with the cannabis program, and she's sitting back there, Erin Portillo. So happy to have her on board. So many of you working on the cannabis program, you'll be hearing from her. We're continuing to work in partnership with the MCA. There's a recent update to the Be Cannabis Smart campaign called Talk with Your Teens About Cannabis Use. There's a great toolkit that's an image there, and you can go to the Be Cannabis Smart website to download that. There's also some videos of providers, and Dr. Kapunen is in them. She's going to be speaking later. So she's like a celebrity, so you should go say hi. So a great overall campaign. And we also have impaired driving, smoke-free spaces, safe storage ads as well, really to build awareness about consumer safety and youth prevention. In addition to the Legal Resource Center, Public Health Policy Tobacco, we also are funding them for cannabis. Great group, I'm sure you've heard from them. Matt Swinburne and his team are wonderful. They put together several documents so that they've been shared, or you can reach out to them. There's their website there, or their email there. For any assistance, they've been out to LHICS to present, and other organizations. So certainly take advantage of their assistance. And another conference, the first annual Cannabis Public Health Conference, will be held May 14th. Registration is open and filling fast. So certainly look for that. We're continuing to support local health departments FY26, and we'll be into FY25 into FY26. And then we have our Cannabis Public Health Advisory Council. The next meeting it's all virtual. It's April 16th from 4 to 6 p.m. It's a public meeting, so you can jump in to listen. But it's a great group of professionals who are able to kind of guide programs to address public health impacts of adult use cannabis legalization. And just to wrap up, I wanted to provide some resources. So in January, the American Lung Association released their State of Tobacco Control report. So happy to say we did go from a B to an A for smoke-free air, and that's largely because we updated the Clean Indoor Air Act last year to include vapes. So we were pleasantly surprised. And tobacco taxes, we did go from a C to a B. A couple years ago, we did increase tobacco taxes on cigarettes and vape products. We're still an F with overall funding and an F with flavored tobacco products, addressing those. That's something that needs to be addressed at the national level. I think only 5 other states received higher than an F, and 3 of those were Ds. So, that's something that really needs to be addressed nationally as well. And remained an A in access to cessation services because we have a great variety at the local, state, quitline, et cetera. Upcoming May 18th is No Menthol Sunday. So this is an opportunity for faith communities to educate their members on tobacco prevention and cessation and the impact of menthol use on their communities. It's a national initiative run by the Center of Black Health and Equity. And the link there, if you continue to check, they're going to have some materials that they can ship or you can download if you're planning a local initiative. So it's definitely a wonderful event nationwide. We also were working with WIC and developed this document, Start Your Journey to Live Tobacco Free. So certainly we're working to update the information on the benefits of living tobacco free before, during, and after pregnancy. I believe we can share this document. We did share it with WIC and they passed it out at one of their recent events. It was a really nice document that we were able to pull together actually pretty quickly, but it looks great. The CDC has new vaping and youth fact sheets. I did go and check. They are still there on the website. So certainly if you want to use these materials, these are downloadable. And then just looking ahead, we want to continue to partner with TCRC and everyone here. Please feel free to reach out. We love to partner. We love to hear from you. What's going on? What works well? Anything you need assistance with? So please, my contacts here, please feel free to reach out to me or any of my other staff. We're here to help and we love to partner. So thank you very much. Let's eat lunch.
We have 2 great speakers this afternoon with us. The first is Dr. Janaki Deepak. She's board certified in internal medicine, pulmonary and critical care medicine, and leads the tobacco treatment clinic at the University of Maryland Medical Center Midtown and the lung cancer screening program at the Baltimore VA. We work very closely with Dr. Deepak, so we have a lot of love for her. She's a great speaker. And then our second speaker is Dr. Patricia Kapunen. If I'm saying it wrong, please tell me. Dr. Kapunen is a teen health expert, double boarded in pediatrics and adolescent medicine. She earned her medical degree and master's in public health from Tufts University. After 12 years of active duty service, she joined the Division of Adolescent Medicine at Children's National Hospital in Washington, D.C. Their fuller bios are on your tables, so please take a look at those. Otherwise, we will jump into our presentation with Dr. Deepak.
Aim today is going to do something I've never done before, speak quietly. So please, because my voice is such that it carries over multiple counties, so I asked for Botox for my voice, but they wouldn't give it to me. What do you do? So here I am talking about pharmacotherapy for tobacco treatment. Some of the slides, I'm going to go off slides. So these slides are going to be available to you, but I'm going to talk a little bit more about the practice of tobacco treatment that I've been doing. And thank you for the state of Maryland, the Chronic Prevention Center, the Center for Tobacco Prevention and Control for funding me. And as I said, David Quinn and Sarah Wolf were the first people I met from the state, and I still remember the day, and it has been a life-changing experience. So thank you, thank you, thank you. Okay, I have no disclosures. I lied. I do have disclosures. I'm very passionate about this.
I am super passionate about this. I want to change everybody's mind about how we think about tobacco treatment, and I want everyone to get energized by this. By the way, during my presentation, if you feel sitting is too much, feel free to stand. I completely am okay. You want to dance, you can dance. Anything is good. Okay, so why should we do this? Why are we asking to prioritize? Oh, okay, there's something wrong. Apparently, the slides are not showing. Oh, we didn't share, maybe that's why. Okay. Are they showing now? Yeah. Okay. Anyway, till now, whatever I talked was smoke. So you're good. For the online viewers, welcome to my session. I really haven't talked much in the other slides, but going on. So why are we doing this? Why should we prioritize, see my words, tobacco treatment to all individuals? And the reason we are doing that is, I'm trying to see if I can bring this to a non-conspicuous place. Because the vulnerable populations, as we've already heard, carry a disproportionate burden of tobacco-related disease. How many of you are feeling some level of stress right now in your life? Just looking, if you look at the news, how many of you feel levels of stress, right? So imagine if you're someone who is having tobacco use disorder, what are you doing right now? You're lighting up anything you can get, or you're putting Zin pouches, or you're doing something else. And there are people who are even more vulnerable, who are doing much more of this, right? Because more than our level of stress, there are people with much more levels of stress. So, and they have limited access to effective guideline recommended treatment services. I didn't change this. I do not like the word cessation, and I do not like the word quit. So you will find me trying to write stopping and treatment. So bear with me on this. If you stop at age 35, so you started smoking early on and you stop at age 35, you get about 6 to 8 years of your life back. And that's good. That's great. If you stop at age 65, I would say between 1.4 and 3.7 years of your life back. And trials have absolutely shown the benefit of providing tobacco treatment to all individuals who smoke. They do not have to have the motivation to stop smoking. Again, keyword, you do not need to be ready to quit. You do not need to have the motivation to stop smoking. We need, as providers, as counselors, as everything, to tell the patient, just try it. You got nothing to lose. Try treatment, you have nothing to lose. That's what I tell my veterans, and they are hardcore. Why is it so hard? These are patient voices. I think nicotine is the most addictive substance in the world. It's a fact, right? So they talk about heroin. There was a slide about heroin addiction. So if you look at the numeric scale, heroin addiction is about 150. And guess what nicotine addiction is? It's 500. Just so that we get it in our head. You are much more likely to stop heroin than you're ever likely to stop nicotine. And the word is nicotine here because that is the addictive substance here. So that's something we need to keep in mind. And one person said, when I left jail, cigarettes were all I could think about. The minute they came out of jail, not like, how am I going to cope with anything else? The cigarettes it is. So it really takes over someone's life. And understanding this, the most important thing is to understand what the brain does when it sees nicotine. Brain, especially the survival center of the brain, which is the ventral tegmental area, which I've written as VTA, it is our safety part of the brain. That part of the brain, when it sees nicotine, instant attraction, love at first sight. And that's it. Then nicotine takes over as the agent to provide pleasure, the agent to provide the dopaminic, surge of pleasure. So it then takes over the pleasure center to make it much more easy to understand. And it becomes the only substance which gives pleasure because the body stops producing that much of dopamine. So when the body stops producing the pleasure hormone dopamine because of so much of surge coming from nicotine, then it becomes essential for pleasure. It becomes essential for survival, and that becomes a problem. So when you tell someone, you know, you're smoking, you have lung cancer, you have to stop smoking, what are they thinking? Oh, I'm going to die. I'm stressed out. I'm more stressed out. When I'm stressed out, I drink water, which is good. But when someone who is smoking is stressed out, they're going to go and smoke more. So whatever you do, please do not tell them, don't you know you have to stop smoking, because we actually do a bad job with that. And then also remember, nicotine promotes everything good. Does anyone who smoke or vape ever look inebriated or anything to you? They look functional, right? You may be in this room talking and then you may go out and smoke, right? You can be a high achiever because it affects all parts of that brain and it actually produces very functional individuals. So it's actually the most sneaky addiction you can ever think of. And you know, they're always conflicted. So I call it the Odysseus effect. They're always conflicted between wanting to stop smoking and picking up that cigarette. So right like Odysseus, right there, attached to that mast, like knows he shouldn't go to the sirens, but no, hell no, going to the sirens all the way with picking up that cigarette. So think about it. I'm bringing in some Greek mythology. I'm not saying that I like to read Greek mythology, but just bringing in some Greek mythology. Now, in 2015, 68% of adults who smoked reported they were interested in stopping. In 2018, 7.5 of the adults who smoked, 2.9 million, successfully stopped smoking. The combined use of pharmacotherapy and what Dr. Bennett does, the behavioral support, really increases the stop rate. But pharmacotherapy is needed. It is crucial. And you know, when you're trying to speak to people, only 31% of adults who smoke have ever been counseled or given medications to stop. How dismal is that? How dismal? Slight increase in those numbers now. So 6.8% using counseling, 29% using medication, and 4.7% only using counseling and medication. And when I talk about medication, when I ask my vets, okay, who gave you, what did they give you for stopping smoking? They say, oh, they gave me a patch. Oh, they gave me a gum. But nobody talks about combining therapy. And I'm going to talk to you about that too. This is the USPS TF task force recommendations for stopping smoking. So everybody should stop smoking. I'm just not going to dwell on it. You can read it. I feel that the biggest mistake we as healthcare people do is we say, if the patient, oh, they're not motivated, why bother with them? Wrong, wrong. We have to buy in it first. So we need to make sure that there is opt-out approach for tobacco and not opt-in. Okay? Opt-out approach, which means everybody who's identified as someone who has tobacco use disorder, vaping use disorder, gets treatment, behavioral therapy and treatment. And talk to them about it that way. Tell them it's a chronic disease. It's like your asthma. You don't ask people to give up their hypertension and diabetes and other things. You don't tell people, oh, you have asthma, you need to give it up. We treat them, right? Right? So why is that so different? Why can't we put our heads around the fact that it should be an opt-out? This was a neat study done by several people where they found that screening prompted by electronic health records, like how we have this wonderful thing set up with Dr. Khanna's team at the University of Maryland, absolutely helps people. So you advise them to stop, deliver treatment, connect them to the other treatment as outgoing, and they really, really yield better rates. So the most important thing you need to do is assess the factors that influence a relapse risk. So when I see someone, I am most interested in this. How is this person going to relapse? And if so, why? So are they adhering their medication? So we have preliminary data from our clinic so far that the people who are adherent with the medications, definitely are much more likely to cut back or quit. Give them kudos for cutting back. Give them kudos. Get them something, be it candy, something, but give them kudos for cutting back because this is so difficult. We have to also look at the social support, the household or other peers who smoke around them, any retained tobacco or tobacco use paraphernalia important, and then insurance. Oh my God, insurance. The less said about it, the better. And then the strategies to improve long-term outcomes are non-confrontational, right? Ask them what will it look like for them if they stop smoking, right? That is a better way. We need to change all those ads which show the plate shirts and the hole in the trachea. This is not how you get people to stop smoking. We need to get messages from the influencers on how to do it better, and we are not doing it better. And then make sure that if you discontinue controller medication, you give them reliever medications. So there are 6 FDA approved medications. There were 7. Nicotine inhaler went off the market. It was our most favorite one as a reliever medication. And it went off the market just because Pfizer said they couldn't find the resin for the mouthpiece. Really. They couldn't find the resin. They just didn't have enough market value. So they decided to discontinue it. It is available on Amazon a little bit as a Nicorette inhaler, but unfortunately not anything else, and it's not FDA approved. So 4 forms of nicotine replacement therapy, which includes the patch. So the patch, the Chantix, and the Wellbutrin. These are your controller medications. They do not immediately do anything for craving. Controller medicines are long-term, like asthma. You give a controller medicine, and then you give that albuterol as a rescue medication, same for tobacco treatment. So let me just go over the other 3 things are nicotine nasal spray, nicotine gum, and nicotine lozenge. Those are your reliever medications. Okay. And you need to assess the knowledge gaps, right? No one has talked to me about Chantix. That's routine because everyone is sitting in the pre-2016 era. Oh, Chantix, it causes bad things. Oh, they have psychiatric disorder. We can't use Chantix. Oh, they can have suicide. No, no, no. There's a beautiful trial. I'm going to show it to you. It was done in 2016. Black box warnings have gone off it. We need to change. Every single person in this room needs to change about it. And, they want to talk to people. They don't like quitting cold turkey because they get that they feel like coming back again. And that is the worst way to stop smoking. Everyone is going to tell me 10 people they know who has quit smoking by going cold turkey. But I can tell you the relapse rates are the highest with cold turkey. Okay. So let's go for nicotine replacement therapy. The mechanism of action, the MOI in that means mechanism of action, is that it's an agonist. That means it likes the nicotinic cholinergic receptors and it kind of activates them to some extent. So this, please, if you all can take away one slide about the patch, this is the slide. I have heard thousands and thousands of people being told this. You cannot smoke and have the patch at the same time. I've heard it's real bad for you. You get nicotine overdose. Wrong, 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 wrong. It's gone off the labeling from 2013 onwards. It's not been there. Please, folks, please, every single one of you needs to live and breathe this and make sure that we are telling the patients the correct information. So think about what is there. The Marlboro Reds have some 13 milligrams of nicotine. Approximate nicotine delivered to user is 1 to 3 milligrams. Not really true. It really depends on their breath hold and their puff size and everything. They can get up to the full 13 milligrams from it. Marlboro Light, same thing. Cigars. Cigars are bad for you. Cigars are bad for you. Anyone who says, oh, I don't inhale, I just puff at it, and this is just a cool thing, it's a man thing, and whatever they call it. No, cigars contain a lot of nicotine. I think I'm trying to speak too loudly, so I'm going to keep it there. And then things like moist snuff are also bad. BDs are horrible. I think I have a slide later on about the vape device. If I don't, I can tell you 3 milligrams of e-juice equivalent to 1.5 packs of cigarettes a day. The Juul device was 40 cigarettes. The Soren device was about 90 cigarettes. So can we please remember that when our high school and middle school students are using the vape device, you are now propagating nicotine addiction. And then the Zyn, and then the Zyn comes very high. And now we're going to get oral cancer in this country. I thought I left oral cancer in India where everyone had chewing tobacco, but it's coming back to this country thanks to Zyn. So let's think about it. The nicotine gum is 4 milligram, but what you really deliver, the lozenge, the 4 milligram lozenge, you're only giving 3.2 milligram. So if you tell someone that you need to use this lozenge every 2 hours as needed when you're awake, you're not overdosing them, guys. You're not overdosing them. Same with the nicotine gum, lozenge, and look at the patches. We say that 21 milligram patch, right? But it's in 24 hours. That means you get less than a milligram per hour of nicotine. So why do we feel so scared to give a 21 milligram patch to everyone? Why are we so focused on trying to give them 7 milligram, 14 milligram, wrong and wrong? So, and then the Nicotrol inhaler, which I love, not because it's Nicotrol, because it's an inhaler, gave up to 4 milligram, but it does not cause addiction. And it only delivers nicotine, whereas the rest of the stuff delivers carcinogens and toxins. So one of the things I do for all my patients is the Phagostom test for nicotine dependence. And it kind of sort of helps dose, but for me, it really doesn't because I use 21 milligrams all the time. That how soon after you wake up, you smoke your first cigarette is very, very, very important. If they say within 5 minutes, then I know that I'm dealing with someone with very high tobacco dependence. And do you find it do you find it difficult to refrain from smoking? I ask them when they're in church, do they still want to go out and smoke? And which cigarette you hate to give up? And do you smoke more frequently in the morning? These are important ones because again, they tell you. And then how many cigarettes you smoke a day is also important. And if you're lying down and you're sick, will you still smoke? Yes, most of them say yes. And this is the dependence score. This is available everywhere. I like this heaviness of smoking index. It's basically taking into account how much you smoke, how many cigarettes you smoke, how soon after you wake up do you pick up that first cigarette. Or even for the vape, there's a slightly different dependence test for the vaping device. And 5 to 6 is high nicotine dependence. And I can tell you that a lot of our patients have this. You just have to be very smart. They also know how to not answer it correctly. Okay, they are very sneaky. So I asked them in different ways. So let's talk about the transdermal patch. It's an agonist. It works in those nicotinic acetylcholine receptors. Why is it important? Because guess where those nicotinic acetylcholine receptors are in our brain? In the pleasure center, in our safety center of the brain. That's where they are sitting. So this one goes boom, right there, gets attached itself, but it only takes about 2 hours after you wear it. And honestly, we are saying 4 to 6 weeks. Are we really expecting someone who smoked for 50 years to be able to give up nicotine addiction in 4 to 6 weeks? Really? No, absolutely not. So I'm giving you the things, but I'm also, my modifications are in red. And you have to consider giving a patch to everybody. Anyone who walks in and they say that they are smoking, tell them nothing, don't worry. You wear the patch, you go and smoke what you want. That's what I tell them. Wear the patch, go and smoke what you want. Over time, you're slowly, they don't like it. They're not able to stand. And I said, when you get that buzzing feeling, do not put the patch off. Put that cigarette down. You understand? Because it's not like a overdose. It's just telling them it's withdrawing almost, right? And they don't like it. So 21 milligrams of nicotine for all. And honestly, I've even given 2 patches if needed. And most of us in our community do 2 patches if needed if they're smoking a lot of cigarettes, because my veterans smoke 3 to 4 packs of cigarettes. So giving them 1 patch is not going to fit it. And this is all being published, and that's the article there. And strongly consider it for more than 13 weeks. Please, please, please. And please use a short-acting medication with it. The patch alone is not going to work. Nicotine lozenges and nicotine gums, again, they peak in 20 minutes. And absolutely have to consider, like they say, the FDA recommends this. I'm going to the third table where I give them all 4 milligrams, because no matter what they tell you, depending on their situation, one day they may be smoking only after 30 minutes, but the next day they may be smoking within 30 minutes. And one day they may smoke 2 cigarettes, the next day something stressful happens, they start smoking a pack a day. So please consider 4 milligrams for everything. And please remember to use it with the patch so that you have a controller and a reliever medication. Nicotine nasal spray, it's pretty fast acting. It's within 5 minutes. It does go up to the brain the same way that a nicotine from a cigarette or a vape device or Zyn goes. That is, it goes up high and it can come down. So of all of them, this is the only thing which comes maybe close to addiction, but it really doesn't addict. And again, you have to use it. We are using this a lot in our Veterans Affairs Hospital in Baltimore, and it is really having wonderful effects. Bupropion or Wellbutrin, it's the medical term is it's a reuptake inhibitor of dopamine. That means it's a pleasure hormone. It controls, it prevents that pleasure hormone from being released. From what we know of it, you have to remember that hepatic impairment, that means you have liver disease, you're pregnant. This is bad because it's kind of difficult. They say seizure disorder is a contraindication, but it's only 1 in 1,000. The risk of seizures with Wellbutrin, and eating disorders is a big, big contraindication. Again, please do not use Wellbutrin alone. It is not effective. Wellbutrin with a patch is the way to go for controller medications, and you need reliever medication. Varniclin. I love Varniclin. I do not have any share in any manufacturer of Varniclin. I like it because it's an effective medication. It actually goes, attaches itself to those receptors in the brain and makes it feel that it's getting cigarettes in simple terms. And the scientific terms are here. I do understand we have a mix of people. That's why I'm also talking about it in simple terms. And Varniclin is something you begin as 0.5 milligram, the lowest dose every morning. Please tell your patients they need to eat a real proper breakfast. If they eat a protein bar or they think that they can get away with a coffee, you will have them vomiting and they'll never use it again. And then you build the dose, then 2.5 milligram BID after after day 4, and then you can go to 1 milligram BID. What are the kind of alterations I do to this? In some people at night, they get weird dreams with Varniclin. So I tell them, skip the night dose, take it only in the daytime. You'll be fine. And they tolerate it very well. Varniclin is not a medicine you can increase the dose. So this is not something you play with the dose. You just can alter the frequency a little bit. In pregnancy, unfortunately, category C, and same with Wellbutrin. And remember, in pregnancy, the nicotine is absorbed very fast. So that is the only place I will give a lesser amount of nicotine patch. So remember about pregnancy and the nicotine absorption. So you have to give slightly less dose. And the biggest problem with Varniclin is nausea. It is not serious mental health condition. So please, everybody embrace this. This is the kid on the block that can make a difference. And it is actually helping even with patients stopping vaping. And again, the nicotine patch along with Varniclin really helps, because Varniclin, by the time it really takes an action, it's about 4 weeks. So you really need something to start off with, along with the reliever medications. And the longest I've had someone on Varniclin was actually a year. Because there have been studies which have shown at least up to 6 months, and in some cases, even more than that. So again, this is what they had told us, right? So this is your strategy. We have to focus in giving them these medications and telling them it is not going to work magically. It's not a magic bullet. I want you to focus not on the goal of stopping smoking. I want you to focus on the goal of taking medication. That's it. Just take the medications, leave everything else to me. Because it's treatment, that means I'm equally liable. The minute you say cessation, only the person is liable. When you say treatments, it's a two-way street. So we have to be there with them. You also need someone to outreach and have I have a wonderful outreach partner, Julia, who's next door giving a talk, and she's the one making all the phone calls. You need that too. So this is the ATS guidelines. These were the specific questions that they had on what is the best treatment initiation. And Varniclin is the optimal controller compared to both nicotine patch and bupropion. And I'm sure we're going to have pediatric guidelines too. I'm excited about it, on seeing where we are going with the pediatric literature on this. And then the combination of Varniclin and nicotine patch actually did better than Varniclin alone. And some other studies say, no, maybe not. But in my practice, I found that giving both of it actually helps. And then what else do we do for people who are not ready to even think of stopping smoking? Give them Varniclin. Give them Varniclin. Absolutely give them Varniclin. And you initiate it even with psychiatric comorbidities. So we do it all the time. Ellie, who's my partner there, Ellie Turcott, our nurse practitioner, she went to the same talk that I went to and the same learning from Dr. Frank Leone, and give it to people and all people. Do not see, but all other people, monitor them. Okay. 14 RCTs comparing Varniclin to nicotine patch. Varniclin increased the 7-day point prevalence abstinence up to 6 months. Absolutely. The ratio was 1.2. And that basically means that you are doing so much more with Varniclin than you're doing with the patch. And they compare 7 RCTs, that is randomized controlled trials, comparing Varniclin to bupropion, again improved. Again, it was superior. This is the trial I want everyone who's worried about neuropsychiatric effects to remember, to read, reread, and think about it. They looked at the most beautiful trial, 8,000 patients, 16 countries. So we had all demographics there. Smokers with stable and treated psychiatric disorder. So excluded patients with substance use disorder. I feel bad because I think they should have, and that has not been done. And they looked at Varniclin, bupropion, nicotine patch, and placebo. What they found was there was no significant increase in neuropsychiatric adverse effects in Varniclin or bupropion relative to patch or even placebo. So this is important for us to know. And it was much more effective in helping someone stop smoking. So it is a very important thing. And how do you start? I mean, even if you're not ready to start, as I've said, 4 randomized controlled trials have shown this, that it still increased abstinence, even if you're not ready to even consider stopping. 2 randomized controlled trials have compared Varniclin with nicotine patch in patients with mental illness, and again found that Varniclin does a better job. 8 randomized controlled trials have looked at the efficacy of extended duration, and it really helps. An extended duration in these trials were about 6 months, and some of them were 12 months, and it did help even at 1-year follow-up. Cystiniclin or cysticin, unfortunately, the FDA decided to kibosh this medication. The plant-based medication
It's similar to Varnaclin. It's a very low cost pharmacologic alternative to Varnaclin, available not in United States. And that also showed the biggest trial there, which was recent, was the ORCA-2 trial. It really showed that the 3 milligrams of cysteine 3 times a day really helped patients stop smoking. So it was a 6-week regimen or a 12-week regimen, and you can see that they really stopped smoking. E-cigarette cessation. Varnaclin again has been studied for that. Randomized to 12 weeks of Varnaclin and counseling versus placebo and counseling, higher continuous abstinence with Varnaclin. And nicotine replacement therapy and counseling for vaping cessation, randomized to 28 days of nicotine replacement therapy and a supportive booklet with quitline referral. Again, it showed that it is a little bit higher percent, but nothing as close to what Varnaclin was. And the Truth Initiative really does a good job in getting the teens and youth, as you heard from Austin, to stop. Now, the thing I'm ready to die on. No e-cigarettes to stop smoking. The clinical trial in England, which loves, and we wrote an article on it in the Blue Journal, which is AJRCCM, and they promptly rebutted it. England said that e-cigarettes were more effective than NRT in 12-month abstinence. In 1 year abstinence, 18% with e-cigarette and 9.9% with NRT. But what they did not tell you is they were either giving them nicotine patch or maybe a reliever. They were not using controller and reliever medications, and they did not use Varnaclin. Okay, so these are adults. We are saying swap to stop, except now, if you look in the participants, 80% of them were still using e-cigarettes. Why not? You're getting so much more nicotine. You're getting all the addiction you want. Why would you go to cigarettes now once you've seen e-cigarettes? It's like whatever it is, the cake, I don't know, like something which is like loaded with sugar versus something which you're trying to make like less sugar-free. Why would you go for the sugar-free version when you have all that loaded sugar? There are some people with long, strong, what do I call it? They are very good about restraining themselves. I'm not one of them. I would have gone for the high sugar. And then the Cochrane review, again, it did not tell you about the side effects of the e-cigarettes that happen. It did not tell you how many people got asthma and other diseases. And it does not really address the fact that the control arm was not actual therapy. So the American Thoracic Society basically says in the guidelines, any day that we should use Varnaclin over electronic cigarettes. So in summary, when initiating pharmacotherapy to treat tobacco dependence, strongly consider starting with Varnaclin. The tobacco cessation clinical pathway of American College of Cardiology, consider adding nicotine to Varnaclin for individuals who are not successful with either nicotine alone or Varnaclin alone. And please consider extending treatment beyond 3 months after quit date. And this includes patients with substance use disorder and psychiatric disorder. And this includes initiating treatment with individuals who are not ready to set a quit date. And the Maryland Quit Line does a wonderful job. It has, for tobacco users, 5 interactions via outbound phone, 1 inbound chat. It really helps. 4 weeks of combo therapy for non-Medicaid, 12 weeks of combo therapy. I do not have any idea what's going to happen with all the Medicaid cuts. Having said that, pregnant tobacco users has 7 interactions, online chats. Tobacco users with behavioral health conditions, 7 calls, as many as necessary, 12 weeks of combination therapy. Youth, they don't like calls, they prefer text. You call a youth, they're not going to pick up. My son is 27, he's not a youth anymore. He doesn't pick up the phone ever. He's also in the military, but no, absolutely not. And standalone web is also there. And then this is our
This is our clinic. We are the Nicotine Health Clinic, and we see everyone. Our contact information is all the way down there. We are in 800 Linden Avenue, and contact Julia Melamed for everything. She's the sane part of our program, me being the insane one. Okay, and the Maryland Tobacco Control Resource Center, we have a lot of available resources. So please, you're here for that meeting. Please feel free to use all the resources. Reach out if you have any questions. I'm always happy to chat. And that's all I.
Thank you so much, Dr. Deepak. So my name is Patricia Kapunin. I am a pediatric trained adolescent medicine physician. Yes, there is such a thing. I have sort of advanced fellowship board of training in taking care of teenagers and young adults. And I'm so happy to be here today. I feel like so many of the speakers this morning stole my thunder in a great way. So hopefully we'll get through this fast and have lots of times for questions. Let me just see with a show of hands, how many people's work includes direct engagement with youth, children, or families? Excellent. Now leave your hands up. How many of the rest of you work with people who have children? And then people who have children themselves, right? So I think this talk is going to apply to most of you, because I think if I get any point out, it's going to be that we all have a role to play in engaging youth in this health issue. All right, I have also no financial conflicts to disclose. I'm really glad that our parking is free. But just like Dr. Deepak, I'm passionate about the care of children and teenagers and young adults, not just in the health clinic, but in all the spaces where they live, grow, and thrive. So I did 15 years in school health. I got to meet the great team, Dana's great team. You may recognize me from the marijuana videos. My children's friends do. It's very amusing. But I got involved in that through my work as a medical officer for a large school system here in Maryland. So all the spaces where teenagers are and all the people who they see every day, it's really not the pediatrician, it's all y'all, right? Including parents, families, counselors, middle school teachers. So thank you for your work and service to youth. We're going to talk about challenges and opportunities, and you'll see this is kind of not really one thing versus the other, because we can take every challenge and make it into an opportunity. I'm not going to talk about the technicalities of nicotine replacement therapy in youth. When we use it for youth, we use it off-label. Our guidelines are still coming, and the studies that we have that show it works are small and underpowered. What I'm going to talk about instead is how do you take an evidence-based practice and actually get it into the hands of youth in a way that makes sense and actually changes lives. And we'll talk about a couple of things. Right, you don't have to like understand these crazy diagrams. I think the takeaway points, besides scientists think diagrams are actually easier than their words, and they're not, is that nicotine affects the adolescent brain in very unique ways. So that dopamine reward center is like front and center in teenagers. It's one of the reasons that they do things that we're like, why did you do that? Right? Instead of the frontal lobes, it's the reward center. And nicotine engages reward in teenagers in a way that's different from adults. And as our last speaker mentioned, it even replaces other ways that that system can then get rewarded. So we see teenagers who are addicted to nicotine are much less likely to do the sweepstakes reward or be rewarded by the other things that would have rewarded them. They're more likely to seek nicotine for reward or other drugs. And then the other diagram talks about the multifactorial physiologic etiology of adolescent nicotine addiction, how the inflammatory response is augmented in the adolescent brain. So the use of nicotine by teenagers is not just like not legal and ill-advised. They actually have more and unique consequences in addition to behavioral patterns that put them at risk for long-term addiction. There's physiologic basis to long-term addiction and the way that their brains respond and their susceptibility for addiction. I don't think that this is something that we communicate very well to teenagers, that the reason that something is age restricted is because you are uniquely sensitive to it. Like people can be more sensitive to sunburn. And your brain you're making decisions that will really affect you in a way that if you use the same substance in 5 years or 10 years, that's not going to happen. So that is a complex risk message in public health. And we do know that teenagers do respond to good risk education. Nobody is as cool as Timothy Chalamet or Anya Taylor-Joy right now. We've already talked a lot about tobacco imaging in film. This is actually from Truth Initiative's post-Grammy article about how every single Best Picture nominee had lots of smoking images. And all this to say that, this quote from R.J. Reynolds about targeting youth, even if we stop that, the messages that have come out of that movement resonate through our culture, right? So I do also agree that images of smoking and looking like a baddie and that's so cool are messages that teenagers are still ingesting, and then e-cigarettes are the safer way to fill that gap. All right. So one of my loves is healthcare operations and health service delivery for youth. I know that's really nerdy, but I want to break it down for you, because when we think, hey, we've got this great medicine, we've got this great treatment, why don't more children get it? That's usually where the gap is between policy and practice, right? So children and young people, even college students, have very developing health literacy and capacity for self-agencies. I will tell you, I have patients who go to college that can't do laundry, they can't brush their teeth, they certainly can't go get a prescription for Chantix, right? So they may not know that these off-label medicines are available to them. And we talked to Almost Dr. Cam during lunch, and he quit on his own cold turkey through Google searches. He didn't know what was offered at his college health services. So even if the medicine's out there, they might not know it's out there or how to access it, right? And those are things that as pediatricians, I'm always reminding people, it's a process. You don't turn 18 and know everything. Any of you who's a parent of an 18-plus-year-old knows that very well. Even though we expect them to, right? So I was in the military for a long time, the largest employer of adolescents in the world, more than McDonald's. And we expected 18-year-old kids, first time away from home, to be able to do everything. And the medicine for them was adult medicine, and that was not the case. They were teenagers with weapons and salaries. All right. So youth rely on others to access health services and support ongoing health management. Maybe we have this cure-all pill and it's amazing, but maybe they're ashamed to go get it, right? They have to declare themselves a user, which will get them into trouble. They need a ride to get to the place, right? They need to be able to pay for it. If their insurance pays for it, the EOB will cause a breach of confidentiality, so their parents will find out about it. They have to know how to go to the pharmacy. I have 18-year-olds calling me from the pharmacy. What do I do now, Dr. K? I'm like, well, walk up there, give them your name, right? So if nobody's taught them these things or can practically support their getting, take the 42 down to the CVS, right? Then how are they going to actually get the medicine? How are they going to get the refills? How are they going to pay for them? And we need to think of all of these things when we're thinking about healthcare service delivery for youth, especially in areas of confidential care, where there's a lot of stigma to the behavior and seeking treatment. And then we talked already a little bit about lack of resources and breach of confidentiality or consequences, right? So I worked in school health, which I love, but schools think in disciplinary practice. They don't think in, oh, you're doing a bad thing, let me help you with that, right? They oh, we found out you're doing this, we have to tell your parents, we have to do this. There's an illegal aspect to that behavior, and it gets caught up in that. And it's very, very difficult to deliver support and discipline. And sometimes there's a paradigm of you either do support or discipline, where you can actually kind of do both together in an integrated way. And then the other problem with that paradigm is that someone needs to actually do something bad to get any attention. So there's a lot of overlay in how we access how teenagers access help and how we offer help to them in a way that they will actually take it. So I guess this is the message. Youth often do not, will not, or cannot access health services they need, even when they are legally entitled to them, and even when they are paid for. Young adults specifically are incredibly underinsured. I talked a little bit about how there are approved treatments for adults that we use off-label for youth, right? So we don't know how they can work in youth better. And when we think about the physiological differences, we assume that grown-up things are going to work in people a little bit smaller. And there's not maybe a difference if you're 19 or 18 or 18 and 17, but if you're 21 and you are 13, there is a difference. In pediatrics, we don't know about nicotine replacement therapy because in the age of cigarettes, we were all about secondary smoke, treating parents. And we were not about nicotine replacement therapy because with cigarettes, youth had a very different ecology of use. It was more social use, and you rarely came up with a kid who had adult pattern smoking who would benefit from nicotine replacement therapy. So now in the age of vaping, high concentration nicotine, we're seeing 14-year-olds with true nicotine addiction. This is kind of a new world for us. And we're extrapolating from adult circles, but we don't always have the data, the health insurance coverage, and that makes it scary to do, right? Policies and regulations designed for children and adults may not extrapolate well to teenagers and young adults. The teenagers live in this policy black box where people build policy for children and they build policy for adults. And when you're a teenager and you're an emerging adult, you don't really fit into either space. So there's not great, or I would say, because I think our state has done a wonderful job thinking about youth, involving them, but people don't always do that. Have you heard of implementation science? That's exactly, how do you get an evidence-based medicine into the hands of a patient, knowing that, oh, we have this cure, now everybody should have access to it, when we know that everybody doesn't have access to it, and it's going to be a work in progress to figure out how to make sure the people who need it most get it. So we don't really have that in pediatrics or youth. This is a very young field, even for adult medicine, I would say. And then the law is confusing. I would say as an adolescent medicine specialist who takes calls from general pediatricians, most of the questions I get could go to lawyers, like this person needs birth control. Am I allowed to give it to them, right? Or what happens if I don't give it to them? What are you allowed to do? And it makes people just want to, put their hands up and walk away and just hope to God when you screen that kid, they say no, right? But what if they say yes? Oh, then there's the Maryland code that says a minor has the same capacity as an adult to consent for medical treatment for advice, medical treatment for, or advice about drug abuse or alcoholism. So according to Maryland code, we should be able to treat children for substance abuse. And there's not a lower age limit like with mental health services, but in practice, this doesn't happen. Children don't know that they have this legal right. Providers are uncomfortable doing it, even if they're aware of what the law says. All right, how do we turn challenge into opportunity? We're never going to have the research. Pediatricians practice in the void of research all the time. So you have to get good at saying, what does the research say? What does it not say? What can we safely do? What's best for my patient and family right now? At the same time, what I hear a lot from teenagers is, oh, you don't know that it's bad for you. There's no research that says that, right? So I was really excited when the first speaker made a relationship between tobacco and adenocarcinoma, now that we're shifting more towards electronic cigarettes, because that is something. If you Google it and it says nothing, it doesn't exist, right? I mean, this is a great clinical tool. If you know what something is and you're like, let's just Google it, and you do this, they think you're a genius. If it shows up on Google, like you have pneumonia, oh my goodness, I do. I have every single symptom in the AI, right? So knowing how to think about research and what is available in research poor spaces is really, really important. So including youth in research and including them in policy implementation. We like to say, oh, teenagers, and nobody understands, and you can't possibly know what I'm going through. And more, I think they're right? I've never been a teenager in today's culture with today's demands and the type of communication and things that they see. So I really don't know. And I'm pleasantly surprised and often like humbled by the things that teenagers will tell me make a difference in their lives. And I talk to them every day. So I think if we don't really listen to what the behavioral targets are, to what they care about, to their extraordinary strengths, we're not going to be able to write policy that works. All right. So barriers to healthcare. What can we do about this? So we can build health literacy. We often educate kids about, what's good and what's bad for them and which vegetables to eat, but we don't check in with them about, when you're leaving home, how are you gonna, where are you gonna go when you sprain your ankle? Or, why do you even take this medicine? How are you gonna learn how to take it yourself? Health literacy is incredibly important and sort of a growing part of, it grows with children. So I'll even ask 4-year-olds, like, what are your health goals today? They'll be like, I don't want to pee the bed, or maybe just once a week, right? So the idea that they have agency to make a change in their health status, and that's not something that they rely on someone else for, is real. Optimize access. So this is why I love school health. I love taking health services to every space where kids go, because they only spend 15 minutes in my office a year, right? So all the things that we're asking pediatricians to do is they're competing for the other things in the 15-minute well visit that we get with them, and taking things to all the other trusted adults like coaches, community spaces, faith communities, schools, those are all the spaces where kids are every day. And then think about treatment costs and the logistics of accessing care. Youth-centered marketing. So we know that flavors bring them in, high nicotine concentration keeps them addicted, and innovation that lets things be hidden perpetuates use. We know that kids like flower themes and rewards. How do we take what we know from the bad guys and use it to market health and market health promotion, right? I'll tell you, when I've tried this, I need teenagers to do it. They do it so much better. We did a health promotion campaign about COVID during lockdown, and we hired experts. We tried to boost our social media, but not until we had actual teams curating the content, telling us what color schemes to use, did we get the engagement that we needed. And we didn't know what they didn't know and what they cared about and what they wanted to know to make a difference in their lives. So youth-centered marketing really needs to be youth-driven, and we can't let the bad guys be the ones who figure it out first. And if they do figure it out first, we need to be able to use that to promote health. And cultivate media literacy. We had a speaker talk about that. Kids hate to think they're being played, right? So even if it's an influencer video about not being influenced, that will influence them. But the idea that big industry is controlling them is worse than their parents controlling them. And then educate youth and families about risk. They need to understand that kids are different. As a, Gen Xer, I have a certain idea about how safe marijuana is or how safe smoking is. And I think that it's the same, but it's not, right? So this is a different time. The risks are different for youth. This behavior can lead to this health consequences. Those messages are critically important. Age-limited restrictions exist for a reason. So we need to explain them, empower our kids and families to be able to understand how to live and work in that environment, especially when there are adult users who may be using responsibly. And I'm not talking about tobacco. Okay. Yeah, I had some opportunities on the other sides, but how do we actually turn opportunity into opportunity? So young people place a high value on peer influence. How do we, as public health professionals and youth-facing professionals, leverage peer influence for understanding how to connect with kids, engage with kids, get them into treatment, right? We know in the substance use field that peer support and peer-led interventions are incredibly powerful. So if you take that, plus the fact that they're at a point in their age where everything that their peers are doing and saying is way more cogent than any scary handout you can give them, that's a powerful tool to be able to leverage. It's important that we normalize good behavior. One of my pet peeves is I mean, I love the Wire BS, love you guys. But like literally for years, it was a national survey detailing all the bad things teenagers did. Like, oh, this year teenagers are doing 27% more of this bad thing. In the recent years, they've actually put in like the good things that teenagers do, right? We don't ask questions about, listen to how many teenagers helped someone across the street or were kind to a friend, but we think of teenagers in the data that we collect on their bad behaviors. And in doing so, we normalize bad behaviors and then they worry about it. They're like, am I the only one who hasn't vaped? Am I the only one who hasn't had sex? When the truth is, most people haven't done these things, right? So normalizing healthy behavior takes shifting culture and changing culture, and then normalizing treatment, I think, is an additional challenge. I think now kids are starting to understand that vaping is not dangerous, is dangerous, but they're too ashamed. So when you change the culture that this behavior is bad, you're also putting a barrier in front of kids who need to raise their hand and say, I need help. So one lesson that we learned, I'll share with you, in Montgomery County Public Schools with substance use services and treatment is that letting kids come forward and volunteer in a peer environment, coming for a friend in a group, just learning, they would bring more and more kids. So like we couldn't say who was ready. If you got in trouble, we were obsessed with what was going on because you got in trouble and you got caught with X, Y, or Z. But if we had like a table in the cafeteria and you could sign up and have a slice of pizza and learn a little bit, that was when kids came forward and they started coming forward in droves when they could self-refer. And sometimes they would come for their friends and bring them in. So this generation is so generous of heart. It's just really amazing. I can't wait to see what they do. All right, technical assistance. So preventive healthcare. Children go to the doctor. We make them go to the doctor. They have to sign forms. We right now vaccinate them and control their access into public spaces based on that. And giving providers, counselors, behavioral health specialists, we have everyone in this room who's done a great job providing technical assistance for how to do these things, how to do them in 15 minutes. The American Academy of Pediatrics, and call up my colleague Susan Wally, who has just done a tremendous amount in this space for youth all over the country, has really great, like, hey, here's a table. This is how you decide how much, NRT to use, when to do it. Here's a 5-question thing. Making it fast, making it accessible is really important. I would say that the barrier in pediatrics is like actually asking about it. Like the words tobacco, the word smoking, they don't work anymore. And sometimes you just have to cut straight to it and, say, do you vape? You have any friends who use carts? I mean, you don't have to use like the cool language, but you need to understand how to ask the question in a way that you may eventually get the right answer. And sometimes I will tell you, I just skip to treatment, right? I just skip to, and I don't go to the, have you held anyone's hand? I say, would you like a pregnancy test today? Or would you like, testing for sexually transmitted infections? Are you interested in help with nicotine cessation? And then they don't have to tell me like whether or not they're doing it or how much. Does that make sense? I really think we need a young adult healthcare model because in pediatrics, we like use the same template, but their needs, their healthcare needs are so different than younger kids and people who are treating in the dyad of parenthood with a parent or caregiver. And then other healthcare spaces. So I'm really interested in juvenile justice and all those other spaces where kids go when kids come into the hospital, right? We treat them with nicotine cessation. That's a great time and space to think about, how are we going to keep going when we finish this hospitalization? Reliance on parents and other trusted adults. Parents are a solution. Families and communities are a solution. They can be the problem, but most often they're a solution. If you watch my cannabis video, it talks about how that voice in a child's life is way more powerful than the random TikTok person that they heard for 14 seconds. So teaching and supporting parents and every grown-up who interacts with kids to understand how to deliver this message about vaping and safety and health is really important. We're now seeing millennial parents who are vaping with infant children and toddlers, right? So that's new in my career, like having parents who are dedicated vapors. So we need to go back to offering treatment for parents and treatment for anybody who is youth facing. And find the trusted adults, because they might not just be parents or family members. Kids go to places in the community where they get connection and feel connected. And it's those connections that they will go to. There's only one question in medicine, pretending you guys are my medical students. It's what is the unmet human need, right? So if you're trying to help someone with a behavior, you can't have them stop that behavior without asking yourself, what is the unmet human need that this behavior is filling, right? Is it depression? Is it boredom? Is it anxiety? And when we're trying to support you, because we know that you want to, we know that it's embarrassing and it causes yuck mouth, right? What do we have to put in place of that? How do we build a life of purpose that we're not just telling kids to walk away from things, but we're helping them walk towards something? And I think that's where family, schools, community, and public health spaces can start to think about, how do I support teenagers? How do I help deliver these messages? And I can talk for hours about each one of these spaces. All right, I'm gonna take a deep breath. I actually want to just take a moment to thank you guys for gathering today. It's a really difficult time to be serving children and families. It's a difficult time to be in public health, and there's a lot uncertain. And just coming here today has meant so much. Just listening to the work that everybody's doing and the commitment and the dedication, and being reminded that life and service goes on is just so important, and it's meant a lot. So that's my thank you. All right, what is unique about your space? I'm actually not, am I done? I might not be done. And then we have time, we have 10 minutes to think about, does where you sit and the way you engage with people, parents, children, inform your role in making sure kids know that it's okay to get treatment, know about the quit line, even if it's something simple like putting up a poster or asking about it, because there's something that everyone in every space can do. All right, and that's it. Thank you.
Thank you to both of our speakers. We have time for questions. We have a microphone around if anyone has any questions. Yep.
Hi. Thank you so much for your presentation for the youth NRT. I had a question. So I am a tobacco coordinator down in St. Mary's County. And I have a lot of parents that come to me asking about NRT for their kids. And they are under 18. And I say, we don't distribute them, or I can't provide certain recommendations. So how would you approach having that conversation with adults that want it for their kids?
I'm so glad you asked that question, because I was thinking about the person who asked before about where should we have that conversation, right? Is it best to have it in schools, or is it best to have it in the family home? And really supporting parents and family members and caregivers as the #1 resource, health resource for children, is so important. So I think how do you talk about these things? How do you bring it up? My first answer to the question, I'm not really hedging, is supporting parents and making sure they know how to talk to their kids about tobacco cessation or nicotine cessation. If that parent has come to you already and said, hey, I want to help my kids stop, I recognize that this is a behavior that I want to support them in stopping, that person is amazing, right? Now I can't speak to the resources in your specific county, but I think starting with the health department to see who is doing that for it's our goal in pediatrics to make sure that this particular capacity, clinical capacity, is available in the community. But unfortunately, it's not right now. And I think there's a lot of variance in who's actually offering it. And it's not very hard. So I bet I bet if you had somebody who was really motivated and parents who were supportive, you would be able to engage a provider, like a family physician, for example, is probably more likely than a pediatrician to be able to provide that support in someone who is not yet 18. And then another plug for the Truth Initiative. I swear I don't have stock, but they have an excellent resource for parents, right, as part of their like BNX. But they have a whole section on, how parents can support their children in quitting nicotine.
Carla Wilson Batty again. This is for Dr. Deepa. So the question I have is, how many milligrams is for the inhaler, and can anyone just go to their PCP and say, look, I'm struggling with cigarettes. Can I get the inhaler, or can you like kind of request what you want, or it doesn't work that way?
I mean, unfortunately, not all primary care has, I think we've done a big disservice by not educating providers about tobacco. So I think it's okay to go to primary care doctor and say, I need a nicotine inhaler because I think it works, except it's not available in the market now. If you go and want to buy a nicotine inhaler, it is not available. It's available on Amazon. So our adult patient who was vaping and who just did not get relief from even using Varnaclin and 2 patches and a nicotine lozenge or gum, he bought it from Amazon as the Nicorette inhaler, and it's 15 milligrams Nicorette inhaler, but it delivers only about 5 to 6 milligrams of nicotine. So that is there. But again, you have to have someone who is there as a resource to tell them what are the effects they may feel when they use a nicotine inhaler. A lot of times you're going to get this. The biggest thing, and Julia does this very well, the biggest thing with a nicotine inhaler is you can't just go. If you do that, it's going to irritate the back of your throat very easily. So it has to be a slow gulp in, like as if you're trying to drink a McDonald's milkshake, which never comes through that straw, right? So slowly you have to inhale it so that it goes where it has to go without causing that. So I tried to do a video of the Nicorette inhaler. That's it. I couldn't breathe after that. By the time I went at it and I went at it wrongly, I couldn't breathe. So the short answer to this is you should be able to go to your primary care physician and say, hey, I've heard a lot about nicotine inhaler, but you also need to be on a controller medicine because the inhaler itself is not going to use. In fact, one of our patients cut a hole in his mask during the whole COVID time, and he always had the nicotine inhaler because it's a dual effect, right? Like someone told about the vape device. It serves as the hand-mouth thing. Mouth. So today, when we don't have a nicotine inhaler, you tell them, like most of them don't like carrots and celery sticks, but something that is hollow and like a hand-mouth thing. So that's a long answer to your short question.
I'm sorry to, I'm so close to our end, but thank you. I had a question about minor consent, if you could address a little bit about that and how we get youth that maybe their parents don't know that they're vaping resources that they need.
So I would answer this question the same way I would for Narcan, contraception, that you really, for it to be 100% confidential, it needs to be funded through a third-party payer, right? So I think it's complicated. Anytime I do something confidentially, which I actually don't do that often, pediatricians are always like surprised as an adolescent doc, how much how important it is to me to bring in an adult, trusted adult. Maybe if it's not the parents, maybe it's an adult sibling or, their uncle who they tell everything to, but making sure they have an adult understand like how to use it, how to get it, is really, really important. So I'll preface that with, I actually do that very rarely, do something completely under the table. But if you do want to operate under minor consent and it would be dangerous to involve a parent, then the way to do that is to make sure you've got all those logistics in place. And usually the easiest thing is to refer them to an organization who can provide that service for free. Does that make sense?
Okay, how do you implement a system such that you are rewarding positive behavior as opposed to punishing the students? So how do you start that process?
So the question is, how do you create a system that you may appear to be rewarding a popular behavior?
Oh, that
Or
so your presentation was how to um start the process, but how do you start it in a system that's punishing the students? You need to turn it around. How do you turn it around?
right. So I think what we need to do is cognitively divorce like discipline strategies from health behavior, prevention, and help seeking, right? We implicitly understand that medical things are confidential, right? But when it comes to school and discipline, everybody needs to know what happened to that person who got caught doing that thing. And if they didn't get anything, then the school and people and adults are being permissive of that behavior. And it's perceived as like rewarding or not being accountable for that behavior. So that's the tricky thing in schools is that schools like tie in help with, you know, first offense, second offense, third offense. If you want the answer to that question from earlier, most schools, school districts, organizations have a code of conduct where they very explicitly say, you know, what can lead to suspension. It all has to be in public education, very scripted. And when you put those things together, like the school can discipline for having something you're not allowed to have at school. And that can be like a hamster, or it could be a vape pen. And then if you have something really bad like heroin, there's a different level of accountability and legal challenge, right? And then there needs to be another side of the school that teaches, right? Schools teach more than anything. This is, you know, how to make decisions for yourself. This is what happens. And if it does happen, this is where you would go for help. Just like would happen outside of the school if they were an adult and they slipped up or did something or, you know, took too much Benadryl. But I think the way to create that is to divorce those two concepts of you get caught and we send you to help or we suspend you, right? So I think someone was talking about alternatives to suspension. Oh, we were talking about that. And like the whole alternative to suspension language means that you don't suspend, you do this instead. But really what's behind that is that, like suspension isn't the answer to a problematic behavior in which someone's health is at risk. Suspension is the answer to something that is egregious enough because it wasn't allowed. And that's completely different from the fact that that behavior also happened to be putting their health and the health of others at risk and the type of help and support they need to not do that again, right? So schools tend to put it that way because we expect schools to do everything and they're not funded to do everything. They're not even funded to do just the education sometimes that they're supposed to be doing. And that's why community collaboration is so important. So that's why I should have said that with my last slide. The reason that like getting all together is so important to me is as a pediatrician, I've got 15 minutes. As a school health doctor, you know, they leave school and they go to 20 other places. As a parent, my kid like comes home and then they leave, right? So someone else in that chain is talking to them. They're listening to them. They're being supported or not supported. So that's why like we really enjoyed good health department support in our public school system because we simply couldn't do it. But we had a partner who could provide that service in a different way that was not the school way. Does that make sense?
All right. Thank you to both of our speakers, Dr. Deepak, Dr. Kunin. That does bring us to the end of our conference. We really appreciate you all coming here today and spending time with us.